Good morning, guys. We are live now, and today we start with our Neuro-Anaesthesia update. And this is going to be panel discussion on neuroanesthesia. It'll be led by Nitin Manora. He's the lead for our neuroanesthesia game initiative. And along with, we have Vijay Kumar Sharma, Mayank, Vinay, and Mukilan. And I'll be handing over the mic to Nitin, who will introduce the faculty and he will tell us about how the day is going to go over. Over to you, Nitin.
Thank you, Dr. Shiv. Happy Shankranti to everyone who's listening. So today is our first meeting for the neuro-anesthesia section. And we thought we'll start with a panel discussion to keep it very practically oriented for practitioners. So the discussions are going to be basic. We'll try to keep it tailored to general anesthetists who practice occasionally neuro-anesthesia. And we also plan to have a lot of discussion. So yeah, so I'm Dr. Nitin. I work in Cleveland Clinic, Abu Dhabi. And so the outline for today's meeting is that we will have some practical discussions on how each faculty does their practice. And we will try to clear out some myths. We will also try to introduce some landmark trials, which can be, which we can draw information from and use them in the practice. And we also plan to have lots of questions and discussions. So please post your questions in the comment section, and we will try to accommodate as many as possible. And we'll also give you lots of take-home points so that you can use it in your practice. So I am joined by an elite faculty panel. And the first faculty is Dr. Vijay Sharma. He is a consultant neuroanesthetist in Walton Center for Neurosciences in the Liverpool. He has trained in Sri Chitra Tirunal Institute in India and then moved on to the UK. So he's our first faculty. Dr. Vijay, welcome to the panel.
Thank you.
Okay. Next, we have Dr. Vinay Bhairappa. He did his DM neuroanesthesia from Nimans, and now he's currently working in Cleveland Clinic, Abu Dhabi, and he has a lot of papers in neuroanesthesia and is a core researcher. So he's also on our panel. Welcome, Dr. Vinay.
Thank you, Nitin.
So I also hope to have Dr. Mayank. I think he'll be joining us through the session whenever he's ready. So he's working as a consultant in neuroanesthesia in Indore. And then we have Dr. Mukilan, who was assistant professor in JIPMER Pondicherry, and now is working with us in Cleveland Clinic. He has done his DM neuroanesthesia from PGI, and he's very academically oriented as well. Hi, Mukilan.
Hi, sir. Hi. Hi to everyone.
Am I audible now? Audio is clear?
Yes, Dr. Vijay, very clear. So welcome you all, and let's go straight into the topics. So the first discussion that I thought we should have is regarding what is your anesthetic technique that you use, whether you use TIVA, whether you use inhalational agents. So Dr. Vijay, can you take this? So what do you do in your practice when you anesthetize neurosurgical patients?
It depends on a lot of factors. It's not the straightforward answer from my point of view. It depends a type of a surgery, type of requirement of a monitoring during the surgery, the extent of a lesion, and how the imaging of the or basically how the pathology is. So in terms of we can divided into two parts, cranial and spinal. So in the cranial cases, the patient, if I'm doing is a cranial tumor case and having a lot of edema surrounding peritumoral edema, or a posterior fossa having a lot of, I'm seeing the patient ICP is already raised and patient has sign and symptoms of high ICP. I try to go for a TIVA, going for inhalational, because it has been proved and seen, and it's in experience that these patients have a good quality of brain relaxation intraoperatively, which gives a surgeon a chance for a better resection, better visualization, and better surgical plane finding.
Perfect. So you mean to say the sicker the brain in terms of neurologically having injury or edema, you prefer TIVA. Is that what you mean?
Yeah, as well as sometimes there is a monitoring requirement. So if the surgeon wants to have an intraoperative neurophysiological monitoring, better we go for a TIVA straightforward.
Okay. Dr. Vinay, what is your choice? Do you use TIVA or inhalational? And in which cases would you precisely want to have TIVA?
Yeah, like Dr. Vijay said. So yeah, it depends on the availability of resources. Like, yeah, there are specific indications for where device up is a necessity. Like especially when you're doing a neuro monitoring. So that time there's no question of using inhalational anesthesia. So in other cases, I would prefer TIVA over general anesthesia, because in the last few years, the last probably 5-6 years, there's a lot of data trickling down, which is showing that total intravenous anesthesia is as an upper hand over the inhalational anesthetics. Like especially in an injured brain, especially there are a lot of data in stroke, a lot of data on tumor excision. So where they have shown that it involves both an in vitro and in vivo study. So they haven't been able to totally translate it into clinical practice. But yeah, definitely the data more weightage is towards total intravenous anesthesia. If you are a resource good setup, where there is no restriction on availability of propofol or opioids, remifentanil, I think you should straight away go with total intravenous anesthesia. But yeah, the question arises in resource restricted settings. Yeah, in such settings, yeah, you have to be more choosy. You have to choose your anesthetic wisely, and there's no harm in using inhalational anesthetics with appropriate monitoring and titrating the MAC levels to prevent cerebral edema. Yeah, but yeah, current evidence, I won't
Points towards
say
TIVA as a better technique. Is
does
that what
not
you're saying?
recommend does not recommend TIVA, but the evidence so far suggests it has an upper edge, slightly better outcomes compared to inhalation anesthesia, and a lot of us will agree, I think, with the awakening, the type of when you use total intravenous anesthesia is much better when you're using propofol based protocol. I think I would agree.
Yeah.
Most of us would agree on that, I think.
Yeah, I think what you pointed out was you should know your resources. If
Yeah.
you're resource rich, TIVA is obviously the better technique. TIVA provides smoother recovery, smoother emergence, better brain conditions intraoperatively, and the various advantages of TIVA. Otherwise, like reducing postoperative nausea vomiting if you use propofol. So a lot of advantages with TIVA for neurosurgical cases, especially for sicker brains. It's preferred to use TIVA. Dr. Mukilan, so how do you do your TIVA? Can you tell us what you should be, what do you use in your TIVA regimen, and what do you take care when you do your TIVA?
So how do my TIVA? So yeah, so mostly our TIVA regimen will be propofol based. So we use an intravenous propofol, and along with the opioid, either we have remifentanil in our clinic, but if I don't have a remifentanil, we can obviously go for a fentanyl infusion or something. So we used to go with a TCI pump, target controlled infusion, with a EEG based monitoring system, so which will guide us to know the depth of anesthesia during the procedure. So for propofol, we have a multiple modes of TCI regimens. We use Snyder and Morse, so preferably use Morse for adult patients, and Bedfuser for pediatric patients, and remifentanil we use Minto model. So if we are using a fentanyl, you can go with I have not used fentanyl in TCI pumps, but I used it with the normal syringe pumps. with the EEG based monitoring system for depth of anesthesia, I would prefer with the, so we use Sedline monitors. So with the EEG based monitor with the TCI pumps, so that will be my options for TIVA.
So you mostly use propofol, you use an
Yeah.
opioid infusion. If you
Yes.
have remifentanil, it's good. Otherwise, in India, we still don't have remifentanil. So you can manage with the fentanyl infusion.
Exactly.
And you also have a processed EEG monitor to guide your TIVA. Is that what you're
Yes.
saying? Because with
Exactly.
inhalational agents, you have a MAC to target to, but with TIVA, you don't have something to guide. So probably you will need a processed EEG monitor. And TCI pump is a luxury. So it will help you drive your TIVA very effectively and to maintain steady state concentration. So if you don't have TCI pump, still you can use continuous infusions and titrate
Yes.
it according to the processed EEG. So we have Dr. Mayank joining us. Hello, Dr. Mayank. How are you?
Hello, sir. How are you? Just
All good.
in an emergency,
So,
still cases going on.
oh, typical neuroanesthetist day maybe for you. So, Dr. Mayank, just how is your practice? Do you use total
I
intravenous
always prefer
anesthesia
to
or
use
inhalational?
no, not inhalational, IV.
Yeah,
My preference is always IV. Touchwood, we have got we don't have a target controlled infusion pump in our setup. We are using the continuous infusion system, and but there is a small thing that I wanted to bring into your notice, that my thesis was on target controlled infusion of propofol and sufentanil. So I had an experience of using sufentanil continuous infusion along with propofol for purpose of neuro-anesthesia cases. And after that, sufentanil was not in a vogue. But nowadays, what we are doing is I am using a continuous infusion of dexmedetomidine, propofol, and fentanyl. So we
very nice.
titrate it on that basis depending upon the BIS levels.
Very nice.
Right.
Dr. Vijay, you wanted to join in, please.
Yeah, just because probably around 6-7 months back, everybody would have heard that UK is struggling with severe shortage of remifentanil, and that was impacted here, and people started diverting from using remifentanil as a default opioid for TIVA. So because we know in India we don't have a remifentanil uses, so we started using a fentanyl. Unfortunately, there is no model available or no TCI pump available which gives a fentanyl infusion, proper fentanyl infusion. So just my request to those who are doing occasional neurosurgery and they wanted to go for a TIVA with fentanyl infusion, please keep background infusions of atracurium or any muscle relaxant infusion, because sometimes if you keep running very high dose of a fentanyl, it will get accumulated after, because context sensitivity half-life of fentanyl is higher compared to the remifentanil, and it will take a long time for a patient to come out and reverse the patient. So what we were doing we were starting with 1 microgram per kg per hour, and after half an hour or 45 minutes, we used to drop it to 0.5 microgram per kg per hour setting. And background infusion of continuous infusion relaxants we used to keep running to keep the patient safe on the pins, specifically when they are doing a deep resections. There's a high chances of having a fatal incidence if the patient moves, if a surgeon is doing a deep excisions and patient moves on the pin. So that's what I wanted to highlight.
Perfect, Dr. Vijay. Point well taken. So if you do not have remifentanil, like in India, you can do a lot of other things, like you can use regional anesthesia, you can use scalp blocks, you can use dexmedetomidine to reduce fentanyl requirement, and these all things come into play. But if you have remifentanil, it kind of makes you lazy, and it kind of makes it very monotonous. Everyone just runs remi, and then you know that everything is going to be managed. So
Just come in,
all of
Nitin.
you,
I just have a
Dr.
point.
Vinay, you can come.
Like Dr. Mayank said, so even I am also using nowadays in the last 1 or 2 years background dexmed infusion, Presidex infusion. It makes a significant difference on your anesthetic requirement. I can say that when I'm using a target controlled infusion, very minimal dose. I think sometimes I get worried. What is the depth with when you're using background dexmed infusion? your propofol requirement to go down target infusion, like target effect site concentration, we can go up to like 2.2. Sometimes you can go as low as that when you're using background dexmedetomidine infusion. I usually follow 0.4 microgram per kg per hour infusion, followed by before giving a bolus of 0.4 microgram per kg. Adjusted body weight. I use adjusted body weight for dosing dexmedetomidine. I would say it does make a lot of like a setup where there is a lot. There's no availability of remifentanil. When you're using fentanyl, yeah, dexmedetomidine as an additive is a very good option where you can maintain a good depth of anesthesia along with probably low dose of fentanyl, and you have to scalp lock. All these things
Point
can
taken.
help you reducing the fentanyl. Yeah,
Point taken.
dexmedetomidine
I
is a
think
good option.
Just a
one
small
more thing
thing.
that we need to stress here is the stage of surgery also. So once the dura is open and the surgeon is on the brain, the requirement for analgesia comes tremendously down. So you can come down on your relax and come down on your opioid requirement. So this has been proven in multiple studies that during the brain phase, the brain is insensitive to pain. So you can have lower, dosing of your fentanyl infusion or whatever is running. Any other infusions anybody else is using? Nowadays, there is a growing trend of using ketamine infusions also, low dose of ketamine infusion. Any experience with that, Dr. Vijay, Dr. Mayank?
We are
No,
not
no, not
using-
I have not used ketamine. I have not used ketamine.
Okay, so you are not a ketamine person. Dr. Vijay?
but we are not using a ketamine, but we are using a high doses of remifentanil infusions up to the 7 mic effect site concentration. The reason is basically we want to keep the patient totally apneic and not movable. Generally, if remifentanil is there, we are not giving any relaxant. So just a dose of relaxant to intubate the patient, and after that, there is no further relaxant. However, when we are using L-fentanyl, fortunately, we have L-fentanyl TCI pumps. That time, because we are not frequently using, so it's just like unknown territory, charting unknown territory. So we are keeping some kind of background infusion of relaxants.
Okay.
One point I just wanted to make, if we are using a TIVA, we have to use depth of anesthesia monitoring. There is no way around. We are giving a TIVA without depth of monitoring, depth of anesthesia monitoring, and that to be monitored. I know there are pitfalls. It's not the 100%, but it gives a confidence level to change our anesthetic technique in between, as well as it gives a safeguarding regarding the medical legal issues, specifically when the patient has intraoperative awareness.
Okay, so point taken. So if you are using total intravenous anesthesia, you should have some kind of a depth of anesthesia monitor to guide your TIVA. And Dexmed infusion is very useful to reduce the requirements of opioids, to reduce the requirement of propofol, and give smoother intraoperative hemodynamics, smoother recovery, many advantages with Dexmed. Ketamine infusions, I must say many neuroanesthetists are starting to use low dose of ketamine infusions, and this helps also to reduce the requirements of opioids and propofol intraoperatively. So these are take-home messages for people practicing in India who don't have remifentanil. So we are talking so much of remifentanil. So you can assume how much of dependence we have outside India of having TIVA with doing TIVA with remifentanil. So for people in India, these are useful take-home points. So in pediatrics cases, so if you anesthetize 1 year, 2 years, pediatric neurosurgical cases, do you still use TIVA, Dr. Mayank? You're muted, Dr. Mayank. So if you can unmute yourself.
Actually, sir, in pediatric cases, yes, we are using TIVA. Definitely, I am using it. The thing is that with the pediatric cases, I am not using dexmedetomidine, but propofol with fentanyl. I am using it, and I'm using again uh, a small. Okay, I know that this is not a good technique to actually monitor, and it has not been recommended in pediatric cases that much. But still, I am using this thing, TIVA, in pediatric cases as well.
Perfect. Dr. Vijay, pediatric neurosurgical cases, Because there are a lot of people who think that propofol for long duration surgeries causes accumulation, causes, the dreaded propofol infusion syndrome. A lot of myths around using propofol in pediatric cases. Is that true, or do you go with propofol?
First, I want to make a disclaimer. I'm not doing a pediatric surgery from last since I have joined a Walton Center, because it's more over that.
Okay.
However, back to Middle East when I was doing, or in India, yes, we can give, as Dr. Mayank said, propofol and fentanyl, which was my recipe at that time. And in Middle East, we were having remifentanil, so remifentanil as well as propofol. However, I haven't seen any propofol infusion syndrome in anesthetics till now. Yes, we have seen propofol infusion syndrome in moreover in intensive care, specifically neuro-intensive care, when the patient is prolonged sedated at least for 72 hours or more than the 72 hours. It all depends on 2-3 factors: what doses of propofol we are giving, how much duration of the propofol are giving, and what kind of a comorbidities the patient is having. But it's much safer compared to all other agents, and I haven't seen in my practical till now.
Perfect. So I have done a lot of pediatric neurosurgical cases back in India. I used to use propofol. There is no need to fear of using propofol in neurosurgical cases. Like Dr. Vijay said, mostly in the ICU, you see this propofol infusion syndromes. And we do not have, propofol can be used in pediatric patients as well, because there are a lot of neurosurgical cases who require IONM in pediatrics, like, tethered cord, spinal dysraphism, anal sphincter monitoring. All these will need, TIVA and without muscle relaxant anesthesia to be given. So you can use propofol in pediatric population as well. So, Dr. Mukilan, in patients who are, in surgeries where IONM is used. So IONM is being increasingly used in neurosurgery, intraoperative neurophysiological monitoring. So what is your technique in IONM?
So for the patients who require IONM intraoperative neuromonitoring, definitely my anesthesia agents of choice is definitely TIVA. So, but I don't say that it should be TIVA. So we can also go with inhalational agents, keeping that your MAC should be less than 0.8. And but I would prefer TIVA because it's more easy to titrate during the procedure, and it will be always helpful for the neurophysiologist so when they communicate with us. So my option is I'll go with a TIVA with propofol and an opioid with EEG monitoring, so that we can monitor, and also with a TOF monitor. So in an IONM cases, so we use a short acting muscle relaxant during intubation. So after that we don't use it. So so my choice will be TIVA with a TCI pump with the EEG based monitor and a TOF monitor. Yeah. Okay.
Dr. Vinay, so do you give muscle relaxants in cases where IONM is used in neurosurgical patients? So some people say initially they give and then they do not give intraoperatively. Some people say they run a low dose infusion or a low, to maintain top of the. What is your practice?
Yeah, but with availability of remifentanil in the last 5 years, I won't require any need to use muscle relaxant after initial bolus dose for intubation. Yeah, back home in India, I used to run a background infusion of very low dose prochronium, and there is an evidence for it. Even a lot of studies have shown that even when you are monitoring MEP and SSCPs, you can keep the TOF count less than 2, and you can still use muscle relaxants. There's no, but you have to just communicate with your neurophysiologist team and with the surgeon what you're doing. So it can be used, but as much as possible, try to avoid it. Like try to improvise, try to use multiple fentanyl, sufentanil, alfentanil, dexmedetomidine infusion, scalp block. So all these things I think would avoid and one of the critical point step during the neurosurgery where I have seen, even with proper depth of anesthesia, when you're not using remifentanil, when I used to use fentanyl and other background infusions was especially when you're doing a CP angle tumor, when they are near the brainstem and they pull, you see a lot of patients bucking. And that was like the critical juncture of the case. So probably during the better communication with the surgeons, please let us know. I'm telling this for people back home in India where they don't have remifentanil. Proper communication with the surgeons probably would help us in avoiding unnecessary movements. Probably you can just increase the depth of anesthesia, give a bolus of propofol or give a bolus of fentanyl or something during that critical phase to avoid unnecessary booking over the tube to these patients. Otherwise, yeah, like I said, depends on the resources. When you're using remifentanil, the question does not arise. So yeah, but muscle relaxant can be used.
Okay, so muscle relaxant can take home message will be muscle relaxant can be used. I definitely use muscle relaxant for intubation and for positioning because by the time they take the baseline recordings for the INM, it's already 1 hour. So you can use your initial dose of muscle relaxant. Then if you have a good standard regimen of propofol and an opioid infusion, you don't need to do a redosing of muscle relaxant and you can use TIVA. Or you can prefer to have a low dose infusion, but the baseline IONM recording should be with the running infusion. So it should be with the running muscle relaxant infusion, and then you compare your IONM recordings later. Okay, so let's move on. Additives, I think we have already discussed dexmedetomidine, ketamine. So suppose you are in a situation where you don't have TIVA. Among the inhalational agents, what would you prefer? Dr. Mayank?
My agent of choice is
Yeah.
usually sevoflurane. Ideally, in the practice, it is always, if we see the entire scenario, if we see from neuroanesthesia perspective and the Indian scenario, isoflurane is available in most of the setups. Sevoflurane is still not available in many of these setups as far as I know. So isoflurane for neuroanesthesia is also a very good choice because it preserves the usual central metabolism in a very beautiful way. But
Very
in
good
our
point.
in our setup, as well as in the general practice, as well as with the cardiovascular stability, taking into the neuro monitoring, we are very happy with sevoflurane.
Dr. Vijay, inhalational agents, if you don't have a TIVA, or suppose you don't, there is some contraindication for doing TIVA. So inhalation, what would you do?
Recently you have, I don't think so. I just wanted to keep an update about 2 to 3 days back. I heard that on a Twitter, NHS is going to decommission all desflurane, so we are not going to get a desflurane now. However, whether the desflurane or not, Sevo was my first agent to be used. After coming here, we are not using isoflurane, but I agree isoflurane can be used if sevoflurane is not available. There is not much difference if we see clinically, there is not much difference if we see cerebral metabolism in terms of using a sevoflurane or isoflurane. But yes, halothane is no.
Okay, point taken. So for all the audience who still have inhalational anesthetic regimen back home in India, it's okay. You can do inhalational agents as long as your principles of neuroanesthesia are good. You are giving a good quality of brain relaxation to the surgeon. You are maintaining your hemodynamics. It's still fine. You don't have to go only the TIVA way. So that's the take-home message, I think. And isoflurane also is very good. SIVO also because it has a low, blood gas partition coefficient and quick recovery also. So SIVO also is very cardiostable. So we can use. So any of you, yeah.
I just
Dr.
wanted
Vinay.
to add a small point on top of that. Like Mayank, Dr. Mayank said, ISO is the best when you compare ISO and CO, especially in stroke patients. When you're in similar to your cardiac preconditioning effect, isoflurane has shown some neuro preconditioning effect as well, especially in cases like with ischemic injury, probably in like an aneurysm or in stroke patients. Yeah, you might consider using when options are available for both ISO and CO. If you're comfortable with ISO probably can come as a first choice, especially in patients with stroke or aneurysm where you expect some ischemia. So isoflurane has shown to be some ischemic preconditioning effect. Like I said, all these are like small experimental studies, but there is a point you can justify your point when you want to use isoflurane. Yeah, but yeah, sevoflurane should be a choice of.
Point taken. Nitrous oxide, yes or no? I want a quick answer, guys, now. So, Dr. Vijay, nitrous oxide, yes or no?
No, not in my practice from last 8 years.
Any reason?
Not specific reason. We have a better agent. That's it. I don't believe that nitrous oxide is the only one who is creating atmosphere changes or all these things, global warming and all those. But we have a better agents and which gives a quick recovery and all those. Though the cranial is a small closed space, and when they close it, there's invariably chances of small pneumocephalus is there, and we don't want to get it expanded using a nitrous. That's only.
Perfect. Dr. Mayank, nitrous, yes or no?
Absolutely no.
Okay, and any reason for that? Absolutely no.
Absolutely no. The reason is that the same thing what Dr. Vijay just said. We are a little bit worried about the pneumoencephalus part, and secondly, we have got better agents available. So it's a time for us to evolve. And at most places in India nowadays, air is also being used. And just as Dr. Vijay said just now, that there is no, but it is an absolute no. The reason is we should avoid it. If we want to see if this particular talk is being heard by the PG students as well, we should stress the point of pneumocephalus strongly. And nitrous oxide is an absolute no in that matter.
So pneumocephalus, air embolism, so we don't prefer nitrous oxide, and we have better agents, so we can do without nitrous oxide. Okay, so one more point I wanted to make is if you don't have TIVA when you do IONM cases, a low dose inhalational agent, like I mean, it will be, it is okay to use a low dose or a low MAC inhalational regimen. So they say 0.5 MAC, less than 0.5 MAC, you can still get very good recordings. So if you supplement it with ketamine or dexmed infusions, you can still get away by not doing a TIVA and still do intraoperative neuromonitoring. So for people back home, if you face this issue, remember this. And unfortunately, desflurane is going out, but desflurane actually, even at 0.8 to 1 MAC, gives a very good MEP recording. So it was very useful, but I think now slowly desflurane is going to go out of the way. Okay, so we've had a good discussion on our anesthetic regimen, and we've completed. So now coming to the next part. So long before, when we did neurosurgical anesthesia, maybe most of the cases we would not extubate on table, and we would take the patients to ICU, extubate them in the ICU slowly, and neuroanesthetists would never extubate patients. I think most of them are happy sending the patient into the ICU. Is that the practice still, Dr. Vinay?
No, it was not very long time ago, Nitin. Even when I was doing my residency back in 2007 to during that period also, we never used to extubate patients, especially after patients aneurysm surgeries or big tumors, CP angle tumors, even CP angle tumors. We never used to extubate.
But now, what is the change? Yeah.
But now the trend is to, if the patient is fit to be extubated, his baseline neurological status, is able to maintain his airway. It should be patient centric. If you feel that patient can be extubated and he can get a good monitoring post-op in a step-down ICU or ICU, you should extubate. The late extubation has got its own complications and incidence of increased pneumonia. You'll not be able to assess the neurological status. So yeah, I go for early extubation. If
Dr. Vijay?
Everything is going.
I think now early and late extubation is gone. The thing is correct extubation, basically. First thing, and I agree with Dr. Vinay that he said about the communication. It's very, very important. So we do communicate with our surgeons. And if surgeon is fine and safe, specifically when they are doing a CP angle and they are nearby the midbrain, or they are doing a critical excision and they know the patient might require a ventilation for a time being, that time we go for shift the patient. Otherwise, almost all the patients are extubated on the table. Sometime our CP angle, if they goes more than 12 hours or 15 hours, something if it has gone up. So we shift the patient just because it will take a little bit more time to come out from anesthetics. So 12 to 13 hours of TIVA. Certainly the patient might take around 45 minutes, 1 hour or 1.5 hours to come out from anesthetics to take out the tube. In that scenario, we might shift. Otherwise, it's a correct extubation rather than early or late extubation.
Okay, Dr. Mayank, what is your practice?
First of all, the most important thing is that the choice of the patient starts from the pre-operative period. So first it is the pre-operative period when we are doing the pre-anesthetic checkup. After that comes the communication with the surgeon. Then comes the intraoperative course, how the patient has behaved intraoperatively regarding his parameters, as well as what kind of tumor and how far the surgeon has gone in terms of dissection process. Then comes the point of extubation. If all these three parameters are fulfilled, then definitely we go ahead with extubation on the table. But if there is a prolonged surgery, if there is a surgery in which too much of handling into the important structures have happened, and there have been some vital parameters, hemodynamically the patient got unstable, then it is we shift the patient to high dependency unit, and then we go for a late extubation.
Very nicely summarized. I think you summarized the whole story. You have to decide pre-operatively, intraoperatively, you have to communicate with the surgeons. And most likely, if everything is okay, we all go for, you can see the trend with all the faculty agreeing that we all extubate early on table, because we want early neurological assessment. So gone are the days when we shift the patient into ICU and keep them ventilated for 24 hours, 48 hours, and until the edema settles down. No, we want to extubate them as early as possible, because we want to know what has been the problem. And the best neurological assessment is an awake, patient after extubation. So you can get to know as to what is happening, and you can catch neurological deficits early, and you can act. So point taken. Now, coming to the next topic which I wanted to discuss, smooth extubation. So a neuroanesthetist, one of the major things about neuroanesthesia is the art of, it's called an art. It's like an art of smooth extubation. So people want to know what is your formula, what is your tricks as to how you can make the patient smoothly, get extubated. So anyone wants to take this? Dr. Mukilan, can you come in on this? What do you do for a smooth extubation, and how do you do it?
So first, when you plan for a patient to extubate on table, so it starts in the intraoperative period. So we make sure that all the physiological parameters are maintained, and I will make sure that patient will be under anesthesia until I shift the patient to the recovery bed. So I don't want the patient to be light in any part of the extubation phases. So like removing during the pinch while shifting with the tube. So I don't want anything to happen. So I'll keep the patient in a not in very deep anesthesia. Make sure that with the depth of anesthesia monitoring, I'll make sure he doesn't buck during the any course of the event. And I like to give some additive agents, like making sure the antiemetics has been given, and I like make to sure that some lignocaine extra dosage can be given to prevent the extubation responses. And in our setup, so we will like to run the low dose of remifentanil even after stopping the propofol, so that can help to smoothen the process. Okay, so I'll make sure that suction should be done during the propofol infusion itself. So these are the steps that can prevent the patient bucking during the extubation. So these are the tips to make the extubation smooth.
Very
and easy.
important point. So, suctioning, removing the pins, shifting the patient on the bed. Don't do it in a hasty way. So in neuroanesthesia, there is no hasty and shortcut. So you do it properly and then start slowly recovering the patient. And then you can do your... Dr. Vijay, you want to come in on this? Any tips for our audience as to how you do this art of smooth extubation?
So I use two things with me. So if the patient is on TIVA, I switch off the TIVA. I don't keep running a background infusion, though some of my predecessors have been using that. What I have found out, if you are quite vigilant, there will be a sweet spot when the patient will open eyes, follow the command. That will be there. If you have missed that sweet spot, then certainly patient will start bucking, and then you probably start you have to give something lidocaine or propofol. So need to be vigilant. If the patient was on TIVA, patient will certainly give a sweet spot to take out the tube with proper monitoring. The second is if I'm doing the case in inhalational, so I always keep two things with me: propofol and levetolol. I don't want any tumor resection, specifically in the posterior fossa, blood pressure to be shooted up high, because we have seen devastating brain injury later on in case of rebleeding, secondary brain injuries. So I don't want the pressures to go up. So I keep levetolol. I know in India we have a metoprolol is quite available, so we can use that also. A small aliquot of 5 to 10 milligram of levetolol is quite fine to keep the blood pressure. And keep a propofol. So generally, once I switch off a CEVO, I keep a propofol with me, and I give 30 to 50 milligram of propofol to keep the patient awakening smoothly. The third thing, if we need to give a reversal, I give a reversal when the patient is on inhalational agent. So there will be, when we give a neostigmine and glycopylate, there will be a tachycardia and blood pressure changes that can be easily over-countered when the patient is deep enough in anesthetics. So all these three things, three scenarios.
Very important. I think this is one point which I would say that is a very important practical point. So you reverse the patient and get him out of the relaxant under the hypnotic agent, and then slowly wake them up from the hypnotic agent. And the sweet spot, like you said, should be a bullseye. It's sometimes you might miss the bullseye, but we try to aim the bullseye every time. And like you said very correctly, that the patient will give you a sweet spot where he can be assessed neurologically. You can ask him to do one command, open his eyes, as well as not buck and no hemodynamic changes, and the tube comes out. So that should be like the typical neuro-anesthesia extubation, smooth extubation drill. But I know we have all struggled. We have all tried that. We do it most of the times, but we fail also many times. But we should try to target this as much as possible. And hypertension during the extubation phase is a no-no. Bucking is a no-no, because we don't want BP2 surgery. We don't want hematomas. We don't want bleeding intracranially. So anything else, Dr. Mayank, that you do in your practice to do the smooth extubation? Okay, I think we lost Dr. Mayank there. Dr. Vinay, anything else you want to add? You need to unmute. Yeah.
So yeah, that's why it's called as an art. It's not called as a science. Extubation.
Yeah, it's not
Okay,
it's not a
so
science, or it's an art. Yeah.
It's each person has their own way in their careers of finding out what is best for them. Yeah, but there are certain like Mukillan highlighted, there are certain points which everybody can follow. Be patient. Try to wait till the surgery, the dressing. Some people I've seen, especially during the early part of your career, you start switching off everything when the skin is getting closed. So try to avoid doing that. This happens when in the initial part of your career, when you're a resident and when you're early in your career. Wait till the positioning is done. Do suction beforehand. Properly position the patient head depth. You may get a lot of obese patients. Position them in 30 degrees, head and elevated. Maintain temperature, maintain glycemia. BP is one of the most important thing, which is not very well, especially there are two scenarios in neuro-anesthesia where extubation BP means also the BP into your post-operative period is controlling is variable. One is SAH and another is stroke thrombectomy patients. So as maintaining a mean arterial pressure, systolic blood pressure more than 40 as is important. Maintaining systolic blood pressure less than 180 or mean arterial pressure less than 120 is also very important in your post-operative period, which is to be continued post-operative care period. So yeah, preventing extubation blood pressure, mean arterial pressures going up beyond 110 during extubation is also very important to prevent rebleeds, re-rupture, re-ICH. So use whatever resources is available. In my setup, I use nicardipine background infusions here. I don't stop till extubation. I titrate them. Another one easily available nowadays is urapidil, tachyben, which is a very good agent. It does not produce any tachycardia, very fast response, very short-acting response. Unlike your Resmolor or beta blockers, where it can produce some bradycardias, tachyben, urapidil is a very good in aliquots of 12.5 milligrams. You can use them. which it produces a very predictable response as well. That what I have observed. And use whatever is there in your resources. Urapidil, labetalol, metoprolol, esmolol, but use it appropriately. So especially before extubation, I would say that, yeah. And like Dr. Vijay said, there is always a sweet spot that sweet spot can be identified only with experience, only with experience and thorough observation. So yeah, you can just remove the tube during that time.
Okay, Dr. Mayank, anything to add?
Sir, I
For
just
smooth
wanted to
extubation?
add one important thing that once these patients are usually on anti-epileptic medicines. So during the process of surgery, there is a blood loss that happens. So it is very important to keep the dose of anti-epileptic ready at that point of time when the hemostasis has been done, and then supplement that dose of anti-epileptic. And because it is an albumin-bound drug, most of them, like epsolin or be levetiracetam, so these drugs are to be given. And these drugs will definitely prevent the episodes of epilepsy that might happen at the time of extubation, or sometimes it might happen. So this is one important thing. Secondly, the process that we follow over here is that once the patient is out of the pin, then only we stop our TIVA. And at that point of time, we do the suctioning. We keep a bolus dose of labetalol, as Dr. Vijay said, ready, as well as we keep lignocaine xylocard ready. And on that process, we extubate the patient.
Very nice, Dr. Mayank. I think your take-home message on the anti-epileptic drugs also is very important. So you need to maintain a good, serum level of anti-epileptic drugs after extubation. That is when the seizures can happen. During intraoperative period also seizures can happen, but most commonly post-extubation in the recovery, in the PACU, in the ICU is when the first 6 hours is you don't want seizures. So you need to replace your anti-epileptic drugs after the hemostasis once the blood loss has happened, so that you reach a good steady state, serum level of anti-epileptic drugs. So many people will give it in the initial part of the surgery, and after 6 hours of a long surgery, hemodilution, blood loss, lot of fluids, the levels of this anti-epileptic drugs can come down, and you can have a seizure in the post-op period, especially in the frontal tumors when there's a lot of cortical handling. Okay, so I think we've discussed a lot. Yeah, Dr. Vijay, anything to add?
That this is the important practice which is changed after coming here. Basically, I was also believing give the anti-epileptics as a routine. So we are not using anti-epileptics now at all, until unless the patient presented in OP with the seizures.
Yeah.
And that too, the patient will have a morning dose of anti-epileptics. We don't give any anti-epileptics during the surgery or at the time of extubation, until unless the patient has a very high risk of having epilepsy or a seizures.
Yeah, I agree. I think there is a tremendous change in practice in that way, that we don't give anti-epileptics intraoperatively. We don't start new anti-epileptics. That's what we are saying. So if the patient is already on anti-epileptics, and then you need to replace the levels. If the patient has presented with seizures, like in many tumors and with very lesions, then you give the dose. If not, you don't need to give a fresh dose. And nowadays, levetiracetam is very, side effect profile is very good, and it has reduced the complications of phenytoin, which we used to give back in those days. So any role for deep extubation? Do you all agree that deep extubation in neurosurgery is, I don't believe in deep extubation, because I want to see the patient neurologically, and very deep extubations, not I think I don't. What do you say, Dr. Vijay?
No, only I've seen few people doing it. That was only a spine case with single
Spine
leg.
is different. Yeah.
No case. Nobody's doing.
Okay, so I think we have discussed most of these things extensively. So eras. So now is the era of eras. So enhanced recovery after surgery. We want to, discharge the patients early. Some centers in the West are discharging the patients on the same day after small tumors or small lesions. So is neuro eras possible, or we or is it not possible? Any take on this, Dr. Mayank? What do you think in your hospital? Do you what kind of patients
No.
would you choose, and what would you will say?
At this present moment, we are not following the ERAS protocol, but there are 3 or 4 important points that we should consider for the purpose of ERAS to be followed. The most important thing is about the size of the tumor, the place where it is. What is the patient like? Are there any susceptible comorbidities with the patient? What kind of incision is to be given when we are performing that particular craniotomy, right? And the most important thing is that how the patient has in the pre-operative period understood the instructions that has been conveyed to you, and then comes the teamwork between the surgeon and the anesthesiologist.
Very nicely summarized. Very nicely. I like your points. Dr. Vinay, what do you think? Is neuro-ERAS possible? And in what cases would you, if I want to attempt early
Yes,
recovery,
yes.
early discharge from hospital,
See,
which cases?
so then one of the, like Dr. Mayank said, one of the main cornerstone for any ERAS protocol, whichever part of the world you do it, in any specialty you do is the patient selection. Patient selection is the cornerstone. Second is the social support that is available. To further improvise on whether the patient has understood, is the family members have understood, what is their backup in case of an emergency, how early they can come back, how will they be able to understand what complications. In Western setups where there is good ambulance services, where they stay nearby to the service, the health centers. For many of them, it would be ideal, but set up in a country like in our country like India, that would be very difficult to implement. Still, certain spine procedures, yeah, like discectomies and other surgeries, you can still do it under daycare where the chance of post-operative risks and complications are very high, less. But in neuro intracranial surgeries, there's no harm in keeping them at least overnight.
Okay, so point taken. Patient selection, I think preoperatively, and then it's still not possible for. It depends on a lot on the patient selection and patient understanding also. So they have to be cooperative. They should know when to raise an alarm, when to come back. So I think now all of us agree that small spine.
Social support system is very important.
Very nice. Okay, so I think we have answered this. So my take would be short surgeries, non-eloquent area surgeries, small craniotomies, which do not involve major blood loss, no comorbidity. So all this preoperatively has to be assessed, and then we can attempt this. Otherwise, it's not feasible. And there should be very good inclusion and exclusion criteria. And preoperatively in the pre-op clinic itself, we should decide whether this patient can be taken for early discharge or not. So it involves a lot of teamwork, and I think regional anesthesia, coming to this point of using regional anesthesia in neuro-anesthesia, is coming up in a big way. So we can reduce our dosages of opioids and cause less nausea, vomiting in the post-op period. And all these things can help in the early recovery of patients. So do you use regional anesthesia in your neuro-anesthesia practice? Dr. Mayank, what all blocks do we, or have we forgotten the regional and we don't use it at all? What is your practice?
Sir, we are conducting a few awake craniotomies for sure. And in that case, we are giving the blocks. We are giving the supratrochlear, supraorbital nerve blocks, as well as zygomatic, the usual for all 5 nerves that is to be blocked. That is one. Secondly, it is in the case of spine also, we are using the erector spiny blocks as well. And these are the 2 things that we are mainly using when we are conducting the cases. And in neuro-anesthesia, that is the practice we have.
Okay. Dr. Vijay, any other blocks you're giving in your neurosurgical patients regularly?
The same thing what Dr. Mayank said, that we are giving either a full scalp block or partial scalp block or selective nerve blocks. It depends on the territory of the surgery, the incision, and all those things. In a spine, in Middle East, we were putting epidurals, long spine surgery. So two epidurals, one migrating cranially, one migrating to a caudally, and then keeping infusion through an elastomeric pump or through a PCI pump.
PCI.
That was there. Here we are not doing that. Previously we were giving a diamorphine. Right now we are not giving a diamorphine, but however the patient is on PCI here if it is a long segment spine surgery. Short segment spine surgery, erector spinae block, but not regularly in the patient who he can be benefited from the erector spinae block. Recently we started having a daycare spine cases. We had a small trial done in 2019, then end up with COVID and all those things, so get lost in between. So daycare spine surgery, single level or double level microdiscectomy, or single or double level of decompression is going to start now.
I think there is a growing trend of using regional anesthesia by neuroanesthetists. We definitely feel that more blocks can be given by neuroanesthesia fraternity to reduce the drugs and to have stable hemodynamics, to help us in awakening. And scalp block, I think not only for awake patients, I would like to tell the audience that even in your routine craniotomy patients, if you use scalp block, it will help you to stabilize your intraoperative hemodynamics, reduce your opioid requirement. Like if you don't have remifentanil, it will definitely help you in your intraoperative hemodynamics. So practice your scalp blocks in patients who have GA, and then when you really need it in your awake patient, it will be good. And I think we all need to emphasize that scalp block is a low risk procedure and low complications, and you don't need any specialized much ultrasound and expertise. Yes, Dr. Vijay, any other point you want to make?
If somebody doesn't want to give a scalp block, there is a way around. Just give a pin site infiltration when they are pinned, and tell the surgeon when they are closing a wound, just to infiltrate the skin at the time of. That will also reduce or drastically come down with opioid consumption.
Yeah, if pin site infiltration in like if you can trap the pin with a V, like you know, you can just infiltrate in a V-shaped pattern and trap the pin. The pin response also can be tremendously reduced. Any other points you want to make? Mukilan, you want to come in on this? Any additives you use in your scalp block?
Yeah, so scalp block, we can use it in all the patients of neurosurgery. It's for an awake, for a normal elective procedure, even for an ERAS. For patients, if you're planning for a ERAS in neurosurgery, scalp block definitely plays an important role, because it helps in decreasing the opioid consumption so that you don't have any post-operative nausea, vomiting chances. So yeah, definitely we can use some adjuvants in scalp blocks, like you can use dexmedetomidine, you can use fentanyl. I have used fentanyl, I have used dexmedetomidine. Sometimes dexamethasone has been also used. So these definitely will help in increasing the duration of action of the scalp block. So definitely we can use the adjuvants. Yeah.
Very important point. I think if
yeah,
you increase the duration, it will last up to the post-operative period also.
yes, yes.
Very nice. Any other adjuvants you are using, Dr. Mayank?
We prefer to add dexmedetomidine and fentanyl along with ropivacaine.
Ropivacaine. Okay.
Ropivacaine, yeah.
Okay.
Ropivacaine.
Mukilan, anything else you want to add?
Ketorolac has been shown recently to do good. Yeah.
So take-home message for audiences: ropivacaine is safety profile, as you all know, is better, and also if you can add adjuvants, it will come longer, and you can the effect will stay for longer. Okay, so like Dr. Vijay said, a partial scalp block also can be used. You don't need to give a full scalp block in a craniotomy patient. You can just target out where the craniotomy, where the pins are, and then reduce your local anesthetic injections also. So we will not go into the details of scalp block here. The topic again will be probably taken up in another session. Okay, so coming to the next topic, tight brain situation. So most of the occasional neuroanesthetist will start doing a case maybe, and then you have a brain which is tight and the surgeon wants brain relaxation. So Dr. Vijay, what would be your approach in this type of cases, and any practical tips you want to give?
I would start with the patient, the position. So the position is very important for any neurosurgical patient, specifically a cranial patient. So the position should, we generally keep a little bit of head up so that venous drainage is not hampered, your neck not very twisted, or airway pressures are not going up very high. So all these things need to be checked. All tumor case, generally they are on dexamethasone. So topping up with another dose of dexamethasone is added advantage. If you have an option, give a TIVA. If doesn't have an option, continue with whatever the inhalational agent we have. So generally, what we do, you start ventilating. So come down with ETCO2, PaCO2 should be, so patient will be hypocapnic for the time being. Then if you want, you can give a dose of relaxant. So if you think the patient is not fully relaxed, you can give a dose of relaxant. If you want, if still it is not there, give a dose of propofol so that there will be a burst suppression if the proper burst suppression is not there. Just reduce your inhalational when you're giving a burst suppression, so that you can even come down with the inhalational requirement. And if still after doing, if still the brain is coming out, you can just tell a surgeon to tap some and take out some CSF. Most of the time it is.
Okay, very nicely answered. I think it starts all from positioning, from your anesthetic regimen, everything. So it all will affect your brain condition. So brain conditions is not something like a magic. It will be from the first step to what you have done, how well you are positioned, how well you are anesthetizing. So all this will be taken care. Dr. Vinay, mannitol or hypertonic saline? The question that we have been discussing for ages.
That's the discussion will go on for a few more decades before end our career, I think. Yeah. Coming to the point, before mannitol or hypertonic saline, identification of the risk factors for brain swelling is the key. Okay, so you anticipate brain swelling before MCA infarct, large MCA infarcts, big tumor, especially meningiomas with a lot of perilesional edema, intracerebral abscesses, traumatic brain injury. Anticipate them. Tell us. A lot of times I have seen surgeons trying to operate with a small craniotomy, then struggling with brain swelling. They may have to may have to communicate with the surgeon. This is the risk factors for a patient having a large tumor or with a lot of edema. He may, especially in trauma settings when the junior surgeons are doing. I think we've all must have encountered this problem, especially during the night when a senior resident is doing the surgery, not an appropriate craniotomy, ending up with severe brain edema. So that open communication between the surgeon and anesthetist should be important to identify the risk factors. Some studies have found sometimes you can just put in a catheter into the subdural space and measure the blood pressure. Right now, I don't remember what exactly the pressures which can predict brain swelling. That can also be done, especially in traumatic brain injury setup. Coming to the question of mannitol or 3% saline. See, that also depends on the source, availability of the source, what you are comfortable with. I know surgeons prefer mannitol. A lot of surgeons would tell mannitol, give mannitol. 3% has definitely physiologically has more advantage. It can maintain the blood pressure. It can, increasing the sodium level to at least 145 is very important. When you're like, the patient is having a sodium level of 120, you cannot expect to give 3% saline and expect 3% saline effect to kick in. So baseline sodium level should be known when you're using hypertonic saline. And as a rescue therapy, you can still use 23.75% hypertonic saline. When you feel that nothing is working in an emergency, patient is crashing, coning, that can be used. But mannitol is also not bad. It's been used for the last 50, 60 years without any major issues. Like make your choice. If you feel that patient is hemodynamically unstable, there is a bleeding, sodium levels are appropriate, go for 3% saline. There's no harm in use. Another advantage of hypertonic saline is you can use it as an infusion. You can use it as an infusion. But when you want to reduce the brain swelling, boluses are known to be much better than maintaining an infusion, because infusions will take time for the serum levels to achieve the target levels. So
I think good points. I think it doesn't matter if it is mannitol or hypertonic saline.
yeah,
Use it wisely. Don't overuse it. Know what all side effects it can cause.
yes,
Dyselectrolytemia. A lot of side effects also can happen, and it definitely helps. But there are a lot of other things also that come into play. And one suggestion probably to the audience that I would give is look at the MRI scan. So if you can start looking at MRI scan and identifying edema, cerebral edema, vasogenic edema, you will know which cases you will find that you can expect a tight brain. So that will help you to prepare better, position better, or anesthetize better. So these are points.
like
Dr. Mayank, anything you want to come in?
obliterated
Most
basal systems.
Yes, Dr. Mayank.
One more important thing that I wanted to tell is that there are two mechanisms by which the diuretics act. There is a mannitol, which is based upon the osmotic diuretic part, and then there is furosemide, which is based upon the loop diuretic part. So it has been observed that after mannitol, if we are giving a loop diuretic, it helps to reduce the brain swelling better. So that is also a concept that can be used by many people where they are using occasional neuroanesthesia, giving occasional neuroanesthesia, or they are giving it in a setup where there is no proper neuromonitoring available as well. So in such cases, they can definitely go for added, depending upon the electrolytes level available, you can go with a loop diuretic as well.
Do you use furosemide, Dr. Vijay, along with mannitol?
Never.
Yeah, I think now slowly we are going away from this practice.
Old concept to use diuretics along with osmotherapy, and it has a lot of disadvantages. We don't
Yes.
want the be hypovolemic. We want a
Yeah.
euvolemic. Already mannitol will get a lot of fluid out from the body system, and top of that, giving a diuretic, it will cause a lot of fluid shifts as well as dyselectrolemia, which is again, it's not good for the patient.
Yeah, I think slowly we have gone away with this practice. Like you said, hypovolemia, a lot of concerns with using diuretics. Okay, fluid therapy. What fluids do you generally use in your neurosurgical cases? Do you use ringer lactate, normal saline? What is your choice?
So generally, we are using a plasma light. It's a quite balanced solution, and
That is what it is.
um, till now my as because once first when you are a novice, when you start doing anesthetics and you give a lot of fluids, then slowly when you become a wiser and you become a miser, you give no fluids and you try to titrate, and you get the sixth sense of not giving a more fluid, because the more fluid you will give, you are doing a more harm to a patient. The patient recovery is prolonged. So there is no harm in giving in a ringer lactate also, because to change the osmolarity of blood, you need to give 8 liters of, we calculated once when I was in residency, 8 liters of ringer lactate. It's a quite huge dose. We don't require, even in 12 hours of surgery, give 8 liters of a fluid. So if you have an option, go for a balanced solution, which is plasma light. If not, then you can alternatively use normal saline and ringer lactate, which is again a very good strategy we have used in the past. But again, fluid is just like a medicine, should be very, very titrated. Patient should not be hypervolemic, not as well a hypovolemic.
Very nice. I think another important point is more fluid you give, the more cerebral edema also will it will translate into. So, Dr. Mukilan, any other point about fluid therapy? What do you want to say?
So I agree with whatever Dr. Vijay said. Yeah. So uh, so initially we were using a lot of fluids, as he said. So now we have been restricting to the plasma light. So I have been using plasma lights in Jipmer. Now we are using ringer lactate. So it's not an issue. So the main issue is the amount of how much amount of fluid you are giving in the intraoperative period. So another point regarding this tight brain is always you maintain the physiology. So that's the really important. So the one point I wanted to make is just check for the tube. When the airway pressures go up, the tube can be kinked. Whenever it is under the drape, it can be missed out sometime. So you check for the kinking of the tubes, and you can see patient can be under there can be low BP. Some low BP can also be a cause for a cerebral edema. So these are the things. So maintain the physiology. First check on the physiology of the patient, try to maintain it, then head up position, and the other steps can carry forward. Yeah, that's it.
Okay, Dr. Mayank, fluid therapy, your choice.
Balanced salt solution. We are using balanced salt solution. But before that, we were using alternatively normal saline along with ringer lactate.
Yeah, I think when we all started with normal saline because it is slightly hypertonic and it reduces the cerebral edema, but slowly we have understood that there is nothing normal about normal saline, and slowly we have understood that a lot of normal saline causes hyperchloremic acidosis also, which is not good for our patients, and we need to give a balanced salt. So either alternate with RL and normal saline, or go directly with balanced salt solution and be very meticulous with your fluid therapy. Take home message for all the audience. Okay, I think we have discussed this. Invasive lines. Do you place in all patients, Dr. Mayank? Central line, arterial line. Any neurosurgery, central line, arterial line should be ready. This is what the previous dictum was.
No, not at all. It again the same thing. It starts from the pre-operative period when we have done the pre-anesthetic checkup of the patient. Very important to have a look about the imaging part of the patient, discussion with the surgeon, where exactly is the disease there, how the patient is behaving hemodynamically beforehand. But in prolonged surgeries, it is always advisable to place the intra-arterial blood pressure monitoring system. It helps us in various ways. First of all, it gives us a continuous monitoring. Secondly, if the patient is diabetic, it helps us to withdraw from the repeated blood sampling processes. At the same time, we can have a good look at the ABG intraoperatively, which provides a lot of information. Regarding the central line placements, it is again depending upon the type of the tumor we are handling, the disease that we are handling, and then only we decide about the central line. Otherwise, no.
Okay, Dr. Vijay.
Art line in every craniotomies. Our reason is as because we want to extubate smoothly. We don't want the blood pressures to go very high, and there's always a lag when we are doing blood pressure monitoring through a non-invasive blood pressure monitoring. So yes, art line for every cranial case. Central line almost nil nowadays. The reason was central line. I feel was previously we don't have any proper vasopressors which can be inotropes or vasopressors which can be given peripherally. But now it is available. Phenylephrine can be given. In India, phenylephrine is quite available and there is no need to give mefentermine, which causes a lot more tachycardia and other issues. And so phenylephrine can be given through a peripheral line and phenylephrine infusion can be used. So, and here we have a metrominol, which can be used through a peripheral line. So almost that was another a shift in my practice when from India to here was no use of central line at all. And believe me, I haven't needed a central line till now in any elective case. In emergency, it depends on the patient, how the patient is bad, and whether you need to start an noradrenaline or other inotropes, or the patient is quite sick in terms of cardiovascularly. Otherwise, elective surgery with ASA1, ASA2, ASA3 patient, no need at all.
Yeah, I think there is a slow shift of practice. We have come down on our central line placements. We do it only when it's absolutely necessary. We feel that there will be a lot of hemodynamic disturbance, or there might be a lot of transfusion of blood and products which may be required. Otherwise, we come down on our central line. Arterial line, still we prefer to have an arterial beat to beat monitoring. And you keep a low threshold for placing an arterial line. So I think the message is clear to the audience. So, Dr. Vijay, do you do trauma cases in your unit, traumatic brain injury? Just summarize what are your goals when you do anesthesia for, a patient who comes with a traumatic brain injury. What are your hemodynamic targets? How you do your anesthesia? And, the basic cocktail for doing a good anesthetic for a traumatic brain injury.
So we do trauma cases, though the cases are already stabilized before transferring to our trust. So generally goal to keep as physiological stable as possible. I know there are a lot of limitation with the trauma patients because sometimes we have a limitation of a history, background history, what is going on and what was having a patient in back. And regarding hemodynamic targets, we don't want a very hypertensive and very hypotensive, not at all. Because we don't want to have a secondary brain injuries. I would preferably, and most of us, we give a TIVA. And their advantage in terms of the TIVA is basically if propofol is also anti-apoptotic and they have oxygen free radical scavenger roles and all those things, then I feel it is a good in terms of reducing the secondary brain injury. Traumatic brain injuries, they have high chances of malignant type of cerebral brain edema and all those things. So TIVA, again, it reduces the chances of that. And most of these patients, they present with the low GCS and they will be a post-operative ventilating. So it's quite useful to just shift the patient with on-ground infusion of a propofol. Blood pressure targets, yes, we generally try to keep mean arterial pressure around 80 to 90 because we don't know if the patient is hypertensive, certainly it will help it out. Even if patient is not hypertensively, it will try to keep the CPP at around 60 to 70, which is basically almost all now meta-analysis suggest the higher CPP we don't require, which is again a counterproductive. 60 to 70 CPP is the adequate for a good outcome. So blood pressure targets we keep around 80 to 90 mean arterial pressure, which gives if the blood pressure if ICP is around 20 or 30 also, it will give 60 to 70 CPP. Regarding mannitol and hypertonic saline, again, I think this will continue to keep going in. If the sodium is fine, I'm happy from my side to give a hypertonic saline, but if surgeon asks for mannitol, I don't have any reservation not giving a mannitol. I'm happy to give a mannitol because these patients, they are not basically already hypoosmolar conditions. They are not in that condition. They are probably fluid resuscitated. So there's no harm in giving a mannitol or hypertonic. Anything can be used.
Okay, Dr. Mayank, anything you want to add with your traumatic brain
Accurately
injury?
summarized by Dr. Vijay. I very well this thing. Just few more important points I want to add is that a quick review with the relatives of the patient in the pre-operative period regarding the history of the patient also can be taken into consideration if possible. If possible, and at the same time have a good look at the imaging part again, as I said before as well. And we have to have good arrangements of the blood products with us regarding and we should be able to inform the blood bank at the same time to keep certain if they're usually like a trauma patient, so sometimes they must be losing blood from other parts of the body as well. So sometimes we might have to activate the massive blood transfusion protocol. So these things are to be kept into mind when we are conducting the traumatic brain injury cases.
Okay. Do you use any tranexamic acid in your practice to reduce blood loss?
No.
Okay. Dr. Vijay, do you use tranexamic acid?
Absolutely. That's what I have missed. So tranexamic acid, yes, always yes.
Yeah, I think a lot of units are using tranexamic acid. Yeah.
It will always,
not
always a beneficial only.
Okay, what is the dose for our audience? If you can just highlight the dose that you use.
Not using it.
So 1 gram bolus and followed by the recent crash trial came. So 1 gram bolus and followed by 1 gram in 8 hours. If you don't have an infusion pump, don't worry. Give a 1 gram bolus and then repeat it after 8 hours, 1 gram again, and keep a TI of 1 gram. That is also well enough.
Do you use steroids in these cases to reduce edema, trauma?
No. Steroid have only role in the vasogenic edema.
Very nice point.
And
these are all patients with cytotoxic edema, so no
toxic
role of
edema.
steroids. So this is Crash 1 and Crash 2 trial. Guys
Crash
who
2
are all
trial.
going for your exams. Crash 1 has no steroids in trauma. Crash 2 is tranexamic acid in trauma, major role. So both are beneficial. I think the other take-home points is avoid hypotensions. No hypotension to be allowed. because the cerebral perfusion is what you want to achieve. And more
Maintain,
BP also is not beneficial because it
and
leads to other effects like pulmonary edema and other effects on other systems. So I think nicely summarized. I think we have discussed
And
most of
and
it.
we
prophylaxis for
missed
the
one.
DVT as well in the post-operative period.
Yeah, DVT
Yeah.
prophylaxis must. Dr. Vinay, anything to add on?
And maintaining blood glucose level within 180 milligram per deciliter is also very important. That has a very
Yes.
significant effect on the post-operative outcomes.
Yeah, I think the secondary brain injury should be avoided, like
Mm.
hyperglycemia, hypercarbia, no hypotension, hypertension, everything, all the secondary brain injury. We have to keep the physiology as normal as possible. Okay, nicely summarized. So, question that the non-neuroanesthetist will ask you in the OR: Can I give spinal anesthesia in a traumatic brain injury patient? So this patient has come with a polytrauma. Head injury has occurred it's like maybe 1 week since the patient has had a traumatic brain injury, and they will come and ask you, can I give spinal? Because they want to give spinal for a lower limb fracture. Dr. Mayank, what do you say?
Secondary brain injury to be avoided. That is what just now we have discussed. So that is my take on it.
Okay,
So
Dr. Vinay, would you
Yeah,
advise
same.
spinal?
See, all these questions arose probably 15 years ago when the options of providing safe GA wasn't available in many places. I think probably these questions should have arisen. But now present scenario with very good anesthesia workstations, safety profile of your general
No,
anesthetic
I
device.
think still the question will. I have been asked this multiple times. For your kind information, I
Yeah,
have
no.
colleagues.
yes, I
After this,
agree with sir. I agree with sir. Many people ask this question even in the CMEs.
yeah.
Okay.
So
Yeah. So yeah, then question is absolutely no. Answer is no.
okay. So for you, it is no. Mukilan, you want to say something?
Yeah, we can give spinal anesthesia. We can grade the traumatic brain injuries. So if it is going to be a mild traumatic injury, definitely I can say yes. Not for a moderate or a severe traumatic brain injury. So for a mild traumatic injury, definitely I'll say yes.
Very nice. Dr. Vijay?
I agree with Dr. Mukilan. We can give a spinal, but in a selected patient, those patients who are stable, recovering, they don't have any sign and symptoms of high ICP, they are neurologically stable, and they have shown a continuous progression.
Very nice. I think you have summarized it very well. So it doesn't matter if you can give a spinal or not give a spinal. I think one more thing is traumatic brain injury is a dynamic process. So the first 2-3 days, there'll be a lot of edema, hypoperfusion, all these things happening. But once the patient settles down after a few days, like a week or so, then the brain also has kind of settled. And then if there are no still signs of raised ICP, or there is no much edema and it's not a very angry brain, so can be attempted. So it is not an absolute answer. It depends on a situation to situation.
May I add
Nice.
something to it? May I add something to it?
Yes, Dr. Man, please.
The most important thing is that you should get a repeat CT scan done of the patient. One neurological scan of the patient is important in your hand. So that will save you medico-legally from the aspects of giving the regional anesthesia in the case of.
Very nice. Okay, so all this we have discussed, avoiding secondary brain injury. I think, okay, now going on to awake craniotomy. So for an occasional neuroanesthetist who's going to face an awake craniotomy, how will you advise? So somebody calls you and asks you, I've been posted, an awake craniotomy has been posted in my hospital. I don't do it often. So practical points, Dr. Vijay, what do you think you can tell them?
If someone hasn't done and hasn't seen, I will suggest not to do it, because it will create a lot of problem for a surgeon, for a patient, as well as for the person himself also. If they have seen how it is conducted, then it's a quite easy to follow it. So every trust or every hospital, they have their own protocol, but for understanding, patient should be very well understood about the procedure and what is going to happen with him. He should be well informed and well cooperated. So the trust or the hospitals, they are doing it regularly, they have the system in place. But if it is not, you are doing occasionally at occasional center, I would suggest, if you can postpone, to send to a good center, it is well. If not, then you have to start from a beginning. Then you have to first optimize the patient, tell the patient to come out, see out how the theater works, how the theater ergonomics, and what are the machines and all those things. Patients should be aware of. There will be a different noises will be there in terms of when they're doing a burr hole. We will keep talking to the patients and all those. So it's a quite big topic to go every step of all those things. The next,
yeah. Go on, please.
The next is the scalp block and the planning and management. It's quite important. So you should have a plan of how you are going to conduct the whole of a craniotomy, and the plan should be in sync with the neurosurgeon. So neurosurgeon should be well informed what you are going to do and what neurosurgeon is going to do from their side. So type of the surgery is very important. Either it is epilepsy surgery or a tumor surgery near the eloquent areas, or it's a deep brain stimulation. So whatever kind of a surgery, it should be. So what we do, because I am working in a neuro center, everything, all this background work is already being done. For me, I don't have to do all these things. So I just move to a morning and I see the list. I go to a patient, I explain them that you are going to be awake, we are going to give a block. Scalp block is very painful block. I have seen patient crying when we give a scalp block. So patient need to be partially sedated and analgesics is given. So I do give a fentanyl, I run dexmedetomidine infusion in the background. When the patient is sleeping, then I start giving a block. Because it is so painful, the patient might have a post-traumatic stress disorders also. And it might create a trouble with the cooperation of the patient. So patient should be sedated, well analgesic should be given, and then only you can give a scalp block. If we have given a scalp block, then we have to give a time so that scalp block should work. So at least 20 to 30 minutes. No before 20 to 30 minutes any clamping. Test the block whether it is working or not. If the surgeon wants to clamp before 20 to 30 minutes, then better give a pin site infiltration and wait for 2 minutes and then pin site it. Then positioning. Positioning is very important. Patient should be positioned in a comfortable position. Oxygen should be supplied. So generally it is by either a nasal prong or a face mask oxygen. Sometimes we can keep our the gas collection tube to just find out some kind of a traces for EtCO2 or nasal CO2. So the patient is not fully draped. These patients are only draped on the cranial part. So other part is open. And then we have to get ready with our plan A, plan B, and plan C. So plan A is we are conducting plan B. What happens if the patient is highly sedated? So what is your airway plan? This need to be clear of. So generally we keep iGel or LMA ready in our theaters. What is the plan if the patient have intraoperative seizures? So it need to be planned and it need to be synced with the surgeon. What is the plan if the patient have bleeding? And what is the plan when we need to convert into general anesthetic? All these things need to be discussed with the surgeon before starting the case. So we need to keep the patient minimal lines. So generally we don't keep artery line in these patients. We keep only a one cannula, and for the sedation or for the fluids, we generally try to avoid Foley's catheterization because that also create some kind of a trouble. Minimal noise in the theater, and patient need to be keep warm. So generally keep blankets or some kind of or generally people we use a bear hugger in other settings. So all these things are minor things. I think it's a quite a big topic to touch through.
I think, but I think you gave an overall gist of the story is that very good communication preoperatively. Preparing the patient is half the game won. So, you win half the things by getting the patient's trust and letting the patient know what is expected, how you will proceed intraoperatively, and choosing the right patients. I think more than indications are motor tumors and speech tumors. But motor tumors, I think again now the IONM has come up and many of them are done in under GA, so you can still do GA and get away. But for speech, when they really have to do the speech testing, that is when the indication is. Contraindications, I think the list should be very, I mean, long and exhaustive. So confused patients, you should never attempt. Obese patients will be really difficult if they snore during the intraoperative period. COPD patients, if they cough during the awake craniotomy, no. Big tumors, vascular tumors, lot of blood loss because you want to have control of ETCO2, hemodynamics. These are all contraindications. So, do you
Psychiatric
do awake,
disorders.
asleep, awake technique, or do you do straight awake, technique? Dr. Mayank, what is your
Asleep,
practice?
awake, the first one.
Yeah.
Asleep, awake, yeah. It is asleep, awake, and then the asleep technique that we
Okay.
follow.
What do you do? What do you use intraoperatively? Drugs?
Dexmedetomidine, propofol. That's it.
Okay. Dexmedetomidine, and then you waken the patient. Once the dura
That's
is opened, you
once the
attempt.
dura is opened, then
You do
right
the testing. Again, you put them back to sleep for the closure.
for the closure.
Okay, very nice. I think this is a popular technique for take-home message for people who are listening. You don't need to keep the patient throughout the surgery awake. During the opening and the closing, it's very painful and unnecessarily you'll keep the patient awake. So you can get away with doing asleep, awake, asleep technique. Dr. Vijay, how do you do your awake?
Apart from it all depends. It depends on the surgeon. It depends on the surgery itself, and it depends on the patient. So there's no hard and fast at my rule. So we are doing sleep, awake, sleep. We are doing total awake, and recently we are doing sleep, awake, awake. So it depends. So we had a good communication between the surgeon before taking the patient in, and we discuss in detail what they are doing it. And we have done few sleep, awake, awake also. So the patient, when they reach the dura, they cut the dura. So after the durotomy, we take out the igel, which we keep for airway purpose. And then the patient is totally awake for the intraoperative monitoring. And once the surgeon is satisfied, then we start just a sedation to keep the patient calm, comfortable, as well all the things in physiological.
So nice. So you use an igel to do your lines, to do the initial stuff, and then waken the patient by removing the igel, and then keep them awake. Is that one technique that you suggest?
Yeah, igel again. Lines are we try to be as minor as possible. So if it's a superficial tumor, we don't keep then much lines. We try to avoid the follies because all these reduces the patient compliances, and patient becomes more and more uncomfortable. So all these things we try to keep as less as
minimalistic.
possible. Yeah, minimalistic.
Okay.
We try to secure airway through igel, and when the patient is final positioned, we check igel again whether we can insert in case of emergency situation arises in that position, because it's very important. The patients are slightly flexed, and if the flexion is not optimal, then probably our igel won't sit back. So that we do these kind of once the patient is sedated, once the patient is anesthetized and positioned. So we take out igel, we see whether we are able to.
Very nice. Dr. Vinay, if you lose the airway in an awake patient or over-sedated patient, or what do you do intraoperatively? You want to secure the airway. So what is your, what advice will you give to any anesthetist who's attempting an awake?
First, rescue LMA is the answer. Probably have to rescue and then have a discussion with the surgeon. Like Dr. Vijay said, you should have planned this, plan B, plan C way ahead. So my first would be to avoid hypoxia. Just put in an LMA and then think what you can. You can always put in a tube through an eye gel. So there is a port you can do, or you can just do a fiber optic, put a bougie or something, and just railroad the ET tube. So my initial choice to rescue as a rescue airway will be an LMA, preferably an eye gel, which can be easily placed with, through which you can nowadays we give
Supraglottic
the
airway
air,
device. Okay.
yeah, nowadays you get air Q as well, similar to which it is like a disposable intubating LMA. You can use that one as well, where you can just railroad the ET tube, fiber optic guided ET tube through that one. So yeah, so these things should be planned very well in fire. Hopefully you
Very
shouldn't
nice.
get into these troubles, but if you get into troubles, you should have this plan B and plan C.
Very nice. I think another important point is access. So you should fight for your access there, and you should let the surgeon, because they have a routine of, you know, draping the patient, taking the whole space. So you need to go to the airway. You should be able to go there. So this has to be emphasized. You have to make sure on that day that you're there for the whole positioning, draping process also. So I think we as anesthetists are more awake during awake surgeries, and you know, you get challenged and you have to watch each step what the nurse and what the team is doing, because they will not realize and they'll just staple the whole drape on the patient. No, no, we are not just given a block on the scalp and not on the whole body. So some things like this can happen. Okay, so I think awake craniotomy also we have discussed. Coming to processed EEG. So depth of anesthesia monitoring, which ones do you, we'll go very fast now. We'll keep it very crisp. Dr. Vinay, what is your depth of anesthesia monitor of choice?
I use a SedLine monitor, which can give both value as well as good EEG with bilateral EEG and spectral monitor as well. Spectral monitoring can be done. So I would use SedLine as a first monitor. But when real estate is just very difficult to get in neurosurgery space, I don't mind using this as well. When you're like patient with a small face, you don't have any malar surface, you can still use this monitor, which can also be used. Basically, need some amount of information on your depth of anesthesia. So see what based on your resource availability.
So your first is SedLine, second is BIS. Mukilan, yes. What is your choice?
So I have used everything actually. BIS I have used the SedLine, and I have used intubate. So hardly I found there is no so there is something on the SedLine. You can see the 4-channel EEG, and then you can see the PSI and the spectral edge frequency. Everything can be seen through the SedLine, but you can use any of these things depending upon the availability. So my preference will be SedLine, then BIS. Okay. Yeah, that's it.
Okay, Dr. Mayank.
My preference would be, as Dr. Vera said, it will be SedLine followed by BIS. But in our availability, we have in our setup, we have only got BIS monitoring available with us, so we don't have any choice regarding that.
Okay, Dr. Vijay, anything else you want to add on this process EEG? If somebody asks you which is the best one, or...
So we have availability of only a BIS, but we keep that spectral array also along with it, because it gives us a visualization of frequency as well as a type of a suppression which we are achieving it.
I think we should know that each monitor will have limitations, and we cannot say none of them are perfect, and we should know how to use them and what to look for. One advice I would give to the listening audience is that look at the raw EEG also, because it will give you vital information whenever there is an artifact, when there is a suction, cautery movement. So you should start identifying those artifacts so that you can do your process EEG monitoring better. So okay,
I want
so
to add
targets.
one more
so
important
yeah,
thing.
Dr. Mayank, tell me. Yeah.
One more important thing is that nitrous oxide. There was a discussion about nitrous oxide. It interferes with the BIS monitoring. So
okay, point taken. Dr. Mukilan, just summarize each monitor and the target for you for each monitor, like for the audience who is listening, trainees.
So for SedLine, we use patient state index. So the depth of anesthesia, which is adequate for the surgery, is between 25 to 50. And for BIS monitor and the entropy, it's 40 to 60. Yeah,
Very
that's
nice.
how we,
Okay.
yeah. That,
So what will happen if you overgive anesthetic or TIVA and you go down? So why some people say, okay, why can't I go down to 20? Why can't I go down to 10? What would be your answer?
so definitely it's going to cause the burst suppression. The metabolic rate of the brain is going to go down. So which is, I don't think it's good for the patient. Yeah.
Yeah. So a lot of studies have shown that burst suppression can cause post-op delirium, post-op cognitive dysfunction. So we don't want to go too deep and causing burst suppression in a non-injured brain. So if you're using it for protection, it's a different story. But in a non-injured brain, if you're using it, I mean, if you're causing burst suppression, it does more harm than benefit. Okay. So cervical spine injury, quick points. Dr. Mayank, what do? You use fiber optic, you use video laryngoscope, or you use normal mills?
Crisp fiber optic.
You use fiber optic. Okay.
Fiber
Dr.
optic.
Vijay?
We are using a video laryngoscope, McGrath, and recent studies have been published that there is not much difference between the spine movement, even if we are doing a fiber optic. It's not like in fiber optic, the patient spine is not at all moved. So video laryngoscope is as safe as fiber optic, and moreover this, what we should use, then I feel, which the person, the anesthetist, is confident to handle in that situation, because it's not a movement, it's other like hypoxia is more dangerous than attempting a person who is not doing a regular fiber optic. If somebody is doing a regular fiber optic, go ahead and
Very
do
nice.
it. If
I think you should know your technique well and don't attempt a technique which you're not very familiar with. In a cervical spine injury, you might lose the airway and you might cause more harm. Mukilan, what is mills? And for our trainees, just tell us what is this mills, and if you don't have have a video laryngoscope and you don't have a fiber optic, how will you do it?
Yeah, so I think it's depending upon the scenario and the sources you have for this procedure. So for mills, it's a manual inline stabilization. So you need at least 2 persons to perform this one. So one who is going to intubate will be standing on the head side, and other who is going to support the cranium at the occiput is going to stand on the foot end of the patient, supporting the occiput and the cervical spine. The role of the person is to make sure that there is no movement at the cervical spine. So while the patient, while the other one who is going to intubate, so it's the mills. Yeah.
Perfect. So either from front or from behind, but stabilize the neck. And even if you don't have these devices, you can still do minimal movement. Okay,
People who are doing freelancing, like
Yeah,
people who are
yeah.
doing freelancing and they are conducting cases of spine, the best thing is that to take the help of the people around you. In India, like many people are doing freelancing. So you just tell them what they are supposed to do, and many people have got the basic sense to help you out at that particular point of time. And as Dr. Vijay said, that preventing hypoxia is much more important. So if we take the help of people around us, we will be able to perform better at that moment.
Yes, Dr. Vijay, anything to add?
just wanted to say that sometimes these patients are transferred in theater with neck collar.
Yeah.
And only I prefer to intubate when the patient is in neck collar only, rather than taking out the neck collar. So that will again give extra protection. That I know the neck collar is not the 100% in terms of neck immobilization, but it gives us some kind of a protection.
Yeah. So what I used to do is I used to remove the front part of the collar if it's very difficult, and then just keep the back part, and so the head is more stabilized. So that is also one thing. Okay, let's move on to neurointerventional radiology. Dr. Vijay, what are the neurointerventional? Now, a lot of endovascular neurosurgery procedures are being performed. Can you just enumerate the name, the indications where endovascular procedures have been performed, and just name them for the audience, and then we will take it.
So I think nowadays the hot thing is intravascular thrombectomies, mechanical thrombectomies, which we are doing, and it's a life-changing procedure, which probably most of the places it's been done, and I assume that most of the hospitals in India are equipped to do intravascular thrombectomies. So it is one of the procedure which is quite hot at present, and I think it's going in correct direction. Other things are more over the elective procedures like aneurysm coiling or embolization, AVM embolizations, or sometimes pre-operative embolization. So it's a stage procedure, the patient taken for intervention radiology to embolize the tumor, which is a much vascular, and then later on taken into the theater to excise it. Then dural AV fistulas are done. So there are plenty of procedures are done. Sometimes there are super selective angiograms are done in terms to find it out, some minor AVM into the spine or in the brain or cervicocranial junctions and all those. So, but among them, if somebody who is not doing regular neuro stuff, I feel they should be aware about intravascular thrombectomy, which is one of the emergencies, and it's a life-changing procedure. If anesthetist has done his job perfectly, the chances of the patient recovery is much better.
Very nice. I think you gave a gist of all the endovascular and neuro radiological procedures that are being done, and this area is growing, and neurovascular procedures can be done endovascularly, and more of these are being done. So Dr. Vinay, you work in a tertiary stroke center, you have a lot of research work on stroke. So just tell us, the audience, if a patient comes for a stroke thrombectomy, what are your practical tips? How do you do anesthesia? Can you give us some brief light on that?
Okay, so like Dr. Vijay Kumar said, it's one of the, in the recent years, it's one of the most important intervention which has changed there. But actually, they say that it's decrease in mortality, number needed to treat for the decrease in mortality is much better than STEMI interventions. So that's how popular and that's how significant it is. Impactful, yeah. One of the impactful procedures in the recent years. I'll just give a few points. Stroke thrombectomies, it's an emergency. Usually the needle to on arrival to groin puncture time should be ideally less than 60 minutes. So you usually don't get much time to see the patient or assess the patient. And the second question arises: what anesthesia are you going to give? Are you going to give conscious sedation? Are you going to give general anesthesia? So each procedure has their own advantages and disadvantages. Don't hesitate to, my answer is don't hesitate to give general anesthesia. If you feel want to give anesthesia, just go ahead and give general anesthesia. But be careful to maintain the blood pressure. Basics, follow the basics. Maintain the blood pressure. Maintain the ideally we say maintain systolic. The Society of Neuro-Anaesthesia Critical Care says maintain systolic blood pressure at least 140, or go for mean arterial pressure, maintaining at least mean arterial pressure of at least 80 to 90. And once the thrombectomy reperfusion happens, maintain the systolic blood pressure less than 180. That is also more important. Positioning is very important. And a lot of these patients can be extubated based on the pre-operative neurological NIHSS score and other things. And don't wait for invasive lines. Don't go in for invasive lines. The main goal is to achieve reperfusion at the earliest. So once the reperfusion is achieved, once everything is done, then you can place an arterial line. Yeah, but if you have 2 or 3 people helping you, one person can intubate and other person can put an arterial line, that would be very good. But my take-home message is don't don't waste time putting an arterial line. Hand over the patient to the patient. Yeah. So it's a time-bound procedure where you have to be very quick, take decisions very quickly, and don't think general anesthesia is unsafe. General anesthesia, if done properly, is as safe as conscious sedation. That is what the recent guidelines say, and that is what our data from our institute also says.
Okay, so the take-home message is time is brain. So you have to do things quickly and give the patient as early as possible to the proceduralist who wants to achieve perfusion. So most of the cases we can do under MAC, mostly for the anterior circulation strokes, which are the more common ones. For the posterior circulation strokes, you might have to give a GA, but everything should be quick, and time has its own disadvantage.
Most of the institutes KPI for in OR to groin puncture will be approximately 10 to 12 minutes. That's the most.
So in 10 to 12 minutes, there has to be a groin puncture. So you will not get any time to prepare. Dr. Vijay, anything with your experience here in this stroke area?
Yeah, we do a lot of stroke thrombectomies, and a recent has been surge in the stroke thrombectomies because it is one of the program which is running successfully, and their small tweaks are also going in. Last year, there was one paper published from a Scandinavian country. They have compared between the GA and the conscious sedation for the stroke thrombectomies, and they have found out there is not much difference in the terms of outcome. But they have found out another, the important observation was there is a high chances of reperfusion when the patient is given a general anesthetics. Forgive me for this. So what we are doing in our setups, we are basically almost every case is going for a general anesthetic. So we don't wait. The reason behind it, if we are in confused whether to give or not to give, the patient goes into cath lab, and then the neuroradiologist is struggling, then we waste another 5 to 10 minutes. So it's better intubate the patient, shift the patient, so the neuroradiologists get the best imaging. Motions are artifacts are nil, almost nil, and they get a best chance to take out the clot and have a better chance of reperfusion.
Okay, so in our institute, we do the exact opposite. We do monitored anesthesia care for all these patients. We give propofol infusions or dexmet infusions, remifentanil infusions, just for, based on the comfort of the anesthetist. And we have found our conversion rate to GA also is very less intra procedure because of imaging disturbance, or like you said, I think it becomes a team effort, and the system also is very important. So whatever you're comfortable and whatever works for you is okay, but the goals are time and avoid hypotension, avoid secondary brain injury, and as early as possible, we have to perfuse the brain. Anything else, Dr. Vinay, you want to add?
Like Dr. Vijay said, yeah, that's what the point was. If you feel to give GA, give GA. So that's what the take-home message is, because it was not the Scandinavian, the recent gas trial. It was named as a gas trial. It was published in anesthesiology, I think, about 4 or 5 months ago. It was a multi-center study in Europe only, which showed that it did not show benefit of GA over sedation. It just said that even all of the there are up to date 3-4 randomized trials which have shown GA is as good as sedation. No studies have shown GA is better than sedation. But at the same time, they have shown, like I said, I agree with you. They have said that the chance of reperfusion was slightly better in the GA group, because the patient's immobility is much better, patient able to access. So also all of these studies do tell you that understanding what type of intervention the neurointerventionalist is going to do is also important. A lot of time, just aspiration thrombectomies are very easy. They can just be done. They are very quick usually. They can be done with sedation only. If the patient is little bit cooperative, and you're able to give only mild sedation. But when you're anticipating angioplasties, stent insertions, or some difficult vascular anatomy, based on your CT scan finding, CT angiography finding pre-op, straight away go for GA. Don't ask the question. So that is where the communication between your neurointerventionist and you as a anesthesiologist comes into play. So my take-home message is, if there's a simple thrombectomy with just aspiration thrombectomy, it can be easily done under sedation, depending on the patient's general condition. I'm not telling everybody, but it can be done under sedation. Lot of these thrombectomies. At the same time, like you said, in the Scandinavian countries, there was in JNSA, there was recently, last year, there was a multi-continental survey in Europe and between in Americans and Australasia. So there they found that even today, almost 60 to 70% of the stroke thrombectomies are still under sedation. That's how much is the, and I was speaking to my lot of European colleagues here. One of the main issues in a lot of these European countries is the availability of staff. So a lot of these stroke thrombectomies are done under by surgeon-guided procedural sedation. So that's also one of the factors affecting the rates for sedation versus general anesthesia. So this is just my take on a stroke.
So, but the gas trial also had a very important point, Dr. Vinay, that it said that whatever is your comfortability, prevent the injury, prevent the time to the brain injury, do it as early as possible.
Yeah,
That
that's
is the
what.
most
So,
important thing. The gas trial said if you are comfortable with general anesthesia, immediately go ahead with general anesthesia, save time.
Yeah, that's what's my take
Like
home.
in our institution, we usually intubate the patient in the ER itself, do the imaging part, shift the patient to the cath lab, and then the things proceed.
Yeah. So that's what. So if you think GA, give GA, but make sure that you are maintaining the blood pressure, temperature, glycemic control, basics of neuroanesthesia are able to maintain. And important thing also is to, one of the things we always forget, overlook is the, once a reperfusion happens, bring down the BP. Don't try to push the BP higher. Try to be moderate. Try to maintain the systolic blood pressure 140 to 180 rather than 180, because reperfusion ICH is very common after stroke thrombectomies, and that has had a very worse prognosis. So that is also one point we usually tend to forget in when you're doing, especially doing this.
Dr. Vijay, any other thing you want to add?
Generally, we have a free availability or frequent availability of Sugammadex, which makes our life easier. So we just intubate with the rocuronium and then reverse it with the Sugammadex in even if it is aspiration thrombectomy. Second is our practical experience. We have found out some of the wake up strokes, or some of the patients who have MCA and they are quite irritable, and they keep moving it even if so. We felt that rather than wasting a time, just intubate the patient, shift them, and I agree with everyone that will reduce the door to needle time. The second is we are not putting an art line on any of the case. We are on just one cannula, and if the patient is coming with the cannula, take with the same thing.
Yeah. Okay. I think nicely summarized. This topic has been nicely summarized. Okay. So next is one question that people ask is what is your hemoglobin target? What is your transfusion trigger in sick brain? So you're getting a neurologically sick brain. You're doing a trauma case, or some injured brain. Like in cardiac patients, in normal patients we tend to keep the transfusion trigger a little lower. But for neuro patients, what are you comfortable with? What is your hemoglobin target, Dr. Vinay?
I would go if there is no cardiovascular comorbidity and patient is fine. More than 8 gram per deciliter should be good enough.
8 is your target.
Yeah. 8 is
okay, Dr. Vijay.
Frankly speaking, there is no clear-cut answer of this. And,
no, we know that there is no answer on this. That's why I'm asking the experts. What is your practice? Because some people say, brain injury, so keep the hemoglobin higher. We want more delivery. So 10 is the target. Some people say 7. Some people say we don't know. So what is your practice, Dr. Vijay?
So one of the trial is going in our center, hemovolution trial. We have divided the patient into the two arms. One is basically we are keeping around 10, and one other one we so just it's restrictive a little bit up to the 7. But it's still going on, and I don't know about how much what is the interpretation is going to be. But from my point of view, moreover, I don't want the patient blood hemoglobin should go below 7 or 7.
Okay.
So
Mukilan?
keeping above 7.
Okay, Mukilan, your take on this?
So I will go with Dr. Vinay. So my target was 8, but if the patient has any comorbidities or multiple comorbidities, I'll go with the 9. So the patients
9.
with comorbidities 9 and without comorbidities 8. These are the
Dr.
target.
Mayank?
I agree with Dr. Mukilan, and it is with comorbidities, it is 9, and without comorbidities, it is 8.
Okay. And I would like to also point out that many of these patients would be volume depleted. So they will be hemoconcentrated. So it might be a spurious hemoglobin that you get. So my target is somewhere around 8 to 9, and probably 9 would be my target. So I don't know. We'll get the answer once the trial is completed. This is one of the landmark trials that is going on. It's called as TRAIN, transfusion in acute neurological injury, and many of the institutes are part of this. So this is one trial. VentiBrain is one study. We wanted to just summarize what is happening. So ventilation in brain injured patients. So there is always a conflict whether you do permissive hypercapnia and the typical ARDS lung protective ventilation. But this leads to rise in CO2 values. But in brain injured patients, you cannot do this. So this is one, very confusing area. So this is one project which is happening in our institute also. Rescue ICP is one trial which came up, which said about decompressive craniotomy being more effective than medical therapy. Synapse ICU came up recently. This is a landmark trial. This showed that ICP monitoring can be beneficial. ISAT was international subacute subarachnoid aneurysm trial. So here, this changed the game and more of endovascular coiling for aneurysm procedures. IHAST and NABIS have said that hypothermia is not beneficial in brain injured patients. So we don't practice hypothermia routinely. We don't induce hypothermia actually in brain injured patients. CRASH, we have already discussed. No steroids and tranexamic acid can be used in trauma patients. Sandman is one more trial which is going on. I think sedation and analgesia practices in neuro ICU. So we don't know exactly what is the answer for that. And hopefully Train and Sandman and VentiBrain can give us more answers. So a lot of research is happening in this area, and we will be able to find more answers in the future. Like you saw, most of us don't have clear answers on many questions. So it's mostly practice-based and each individual-based answers. So quite an exhaustive discussion.
And one more trial.
Anything else?
The thing is about the post-operative ventilatory aspects. Like I would like to ask Dr. Vinay, what is the practice? Does he continue dexmedetomidine or he prefers to use remifentanil? What is his practice?
In our institute, as a practice, it's we use propofol and fentanyl as a background infusion in our institute. We continue. And when we hand it over to the ICU, usually by early morning, they wake up the patient and then try to extubate the patient. So there's no policy as such. Usually, there's no. I know that fentanyl can produce a long-lasting effect when you use it as an infusion, but as a first preference, I usually continue propofol and fentanyl and shift the patients to ICU. Usually, try to extubate them early. And depending on the agitation and all, then dexmedetomidine, midazolam, all these are considered. I don't have any clear answer. There's no any particular agent, but in our institute as a policy, most of the patients are shifted on propofol and fentanyl.
Dr. Vijay, what do you practice for your?
We are using a propofol and L-fentanyl. So if compared with the fentanyl, L-fentanyl is a shorter acting and it has a better. Again, these patients are quite tricky ones, specifically those who have traumatic brain injury. Sometimes it's not quite straightforward, stop the sedation and then extubate. So probably we need to add some oral sedation and slowly make them in a condition where we can extubate them. Midazolam, generally we are not using it. Morphine, in India, I have seen some centers, they use the morphine and midazolam, we are not using at all. And I think they are long-acting agents should be avoided as much as possible. The other one, sometimes we use a midazolam specifically in case of epilepsy, those who are epileptic patients chronically, and we need to burst suppress, and it is not burst suppressed with propofol. Then we add midazolam in those patients.
Dr. Vijay, what is the dose of alfentanil that you use?
We are using in adult patient, basically we are using a 10 to 20 milligram per hour.
10 to 20 milligram per hour.
Yeah. So it's around one alfentanil comes as I think 2 milligram in a one small ampule and 50 milligram a vial.
Yes. It's it's 1000 milligram, 1000 microgram per ml concentration. Yeah.
So we are using 10 to 20. I think around 10 to 15, but it depends. Sometimes we can go up to the 15 and we can come down with the 10 also.
Okay. Anybody using fentanyl for post-operative in the ICU period like?
No.
Dexmedetomidine?
We do use sometimes. Sometimes we use. But it's not a first choice, sir. It's not first choice.
Pardon me if I'm wrong, but I have seen dexmedetomidine. It's quite unpredictable. Some patients, they respond very well. I have used even in back home also. But some patients, they don't respond at all with dexmedetomidine. And then we struggle a lot. So we have to come down back on our traditional sedation of propofol and elfentanil. But
And I think one more thing is with dexmedetomidine, it causes this bradycardia, which kind of masks your raised ICP situation where the intensivist is not happy to have a bradycardia because of dexmed, and he'll be confused whether it's bleed or any emergency increase in ICP, and he can call a code brain or this is because of dexmed. So I think there is a factor there with that also. Okay, I think it was very exhaustive, nicely covered. I'm very happy about the discussion that happened. I really have to thank all of you for your time. Dr. Vijay, you should get back to your daughter. And it's a festival day today. Dr. Mayank, we thank you for joining in. Dr.
Thank you so
Mukulan,
much, sir.
Dr. Vinay for taking your time out. Dr. Shiv, whatever you say now.
He's not unmuted.
Still, my case is going on.
Thank you, Nitin, for hosting this session, and thank you, Vinay, Mukilan, Vijay, and Mayank for being the panelist. I think a wonderful discussion. There are a few questions and comments on the chat session, so I'll just quickly go through them.
Okay.
Vikar Qureshi is asked about role of regional blocks on the intraoperative neuromonitoring. I think if I'm not wrong, this question is related to use of erector spinae block and neuromonitoring, which is actually been asked constantly. I think, is there an effect of that?
Can I take that, Dr. Shiv?
Yeah, sure.
So in our institute, we give erector spinae blocks for all your scoliosis patients, and we are trying to use it for long spine patients as well. So the important point is erector spinae block can cause a drop in evok potentials in the intraoperative neuromonitoring. But the easier way to deal it is you don't resist to give a block and then ask the neurophysiologist to take a baseline recording once the block has given in and it is settled, like 15-20 minutes after the block. You have ample time. These are long surgeries. So then you get your baseline recording and then keep comparing your further neuromonitoring values with that baseline. So take home message, erector spinae block can cause drop in evok potentials. Get your neurophysiologist to do the baseline once the block has been placed. That's it.
Yeah, our spine surgeries moved to Vijay's center. So when I was doing the spine cases, I used to give those patient blocks. I started giving erector spinae block much before even it was published. That's also spine, because I was looking for something which would be useful for spine surgeries. And my impression, well, as far as neuromonitoring is concerned, the surgeons as well as the physiologists didn't have any problem, because I gave this blocks in the theaters, and then the patient actually moved and they had used the baseline and things. So it was never a problem. But as far as pain control is concerned, it's good for acute cases, for patients you have secondaries, for stabilization, it's fine. For chronic pain patient, intraoperatively, fantastic. Post-op doesn't work because pain is in the brain, not at the local level. So that's the difference between that. So we can use it. It's not a problem. Regarding deep extubation, Gurunath Murthy was asking about what about using lidocaine spray to vocal cords? Do anybody use that?
No, we are not using.
No, I don't think so.
Vocal, I think it's the whole posterior pharyngeal wall and all those things are involved in that gag reflex. So it's the whole gag reflex which causes a bucking and coughing and all those issues.
No, I think for neurosurgical cases, one of the important points is that the reflexes should be back as well. So we don't want patients who don't have good reflexes, who might aspirate. If the conscious level is less and they don't wake up nicely, they have an issue. So we don't practice this blocks. And in fact, even in the airway blocks, when we do fiber optic, most of us, I think, have moved from airway blocks to using dexmedetomidine and spray as you go technique, and less of this long lasting blocks too, so that we can minimize this issue.
This has not been asked, but this is a question from me. I know that people have been using lignocaine infusions as well.
Yeah.
I'm not talking about the giving bolus of lignocaine at the end, but if you are using lignocaine infusion as part of your analgesia technique, do you find that extubating the trachea is easier or smoother? Has anybody got any experience on that?
No.
Yeah.
After
Okay,
there has
Jay.
lidocaine infusion, basically in spine case, long segment spine case, give a bolus of 1 to 1.5 microgram per kg, and then infusion of 1 microgram or 0.8 microgram per kg per hour. They take a time, they take around 5 to 10 minutes extra, what I have seen with my traditional practice. But one is a smooth, the second is they complain less pain, less opioid requirement in recovery.
Sir, I have not used it in cranial cases, but I've used them in the spine cases.
Spine cases, yeah. Yeah. I mean, I
I
can
have
see
not used
Dylan as
this,
well
Dr.
shaking his
Shiva.
head, and so there is obviously. I think if I'm not wrong, if you look at the physiology, cerebral physiology, lignocaine is the only one which suppresses the the electrical activity which is required for housekeeping. You can call about burst suppression and thing, but there is a baseline electrical activity which remains, and the lignocaine is the only one which suppresses the this activity, housekeeping activity as it is called. And this can be the reason why, if you continue that, the patient might be actually slow to wake up. Is that right? Do anybody observe that? If Vijay,
Sir, they take 10 minutes extra to wake up.
All patients
They
are
take
waking
10 to 15 minutes extra.
They need require a little bit of time extra. Thank you. Okay. Then this was actually from Dr. Raghavendran. He was talking about SIVA. SIVA is a combined use of intravenous and volatile anesthetics for, again, in patients who you want to extubate the trachea deep. And he also commented about use of sugammadex, and that is if you're using rocuronium for deeper extubation. I think it was more of a comment than of a question. This is from Vikas Qureshi again, and Dr. Bharti Mohan, a senior anesthetist. Use of supraglottic device to replace the endotracheal tube, the Bailey's maneuver. Does anyone practice that for smooth extubation? Or you would go for what you have described, that look for that sweet spot, wait and just take it out. Does anyone?
No, we don't.
Not in neuro.
No.
It's not a common practice in neuro.
No.
I think it's a personal choice. Few people they do it. I've seen one person doing it in whole my career. But again, if somebody has got the right thing in the ET tube, taking out the ET tube, then it's just like a wasting of resources. Again, you'll take out ET tube, put a new eye gel, and then you'll throw that eye gel out. So it's a personal choice rather than being a widespread practice.
This is obviously not a neurosurgery, but some neurosurgeons do carotid endarterectomy, and it was a thing. I think this is before we were using more of the not the bio patches like the bovine pericardium and the I think porcine pericardium, which is actually better hemostasis. They were worried about increase in children blood pressure and having a hematoma, neck hematoma. People were using it, but I think one of the things which people tend to forget, if you are using a supraglottic device, especially the one with the cuff, and you overinflate, it does actually have effect on the blood flow to the brain through the carotids. It does so that is known. It has been studied. I don't know whether that would maybe a reason why it is not used in neuro patients. Any comments on that effect of Mukilan is shaking his head.
No, I think we are all comfortable with a tube
exactly
in place,
yeah.
and I think makes our job more easier with a tube properly placed and cuff raised. I think we are more comfortable.
More comfortable.
with
It
that
is all
because
about the reflexes being intact, and then you
Mm.
remove the tube. It is
Absolutely.
more about the prevention of the aspiration part.
That's very right. I think that also comes to the fact that you wouldn't want to have an insensate vocal cord with lignocaine, and then actually if you get aspiration, then it's no point, isn't it? You have done a wonderful neurosurgery,
I
but
have-
the patient, Mukilan,
Yeah, I had an experience during my residency. They were using 1 ml of lignocaine or xylocard in the vocal cord and wait for 2 minutes so that the patient won't bug during this one. But I have not seen a good response actually.
Yeah.
And more we worried was, so more we anesthetize, the more chance of a patient going losing the airway. That's really problematic. But I don't feel that gives any advantage during extubation. I had some experience.
Absolutely.
And Dr. Shiv, most of this like spraying, all those things are, I think, personal practices preference. I think there is no studies or large scale studies to back them up. Like even dexamethasone, which is like left and right used by most of us to prevent airway edema. Unfortunately, there is no large scale randomized studies or anything to back that up. It's so interesting, right? Like I think almost most of us are using, I think, dexamethasone, right? Airway edema.
Absolutely.
To prevent airway edema.
I use it for all.
But if you see in the literature, there are no randomized studies to back that up. So all these are, I think, mostly personal choices. But physiologically, if you say spraying something when you want to recover the full upper airway reflexes, spraying something just to prevent that is, I think, it's not right, because we do a lot of endoscopies here. Sometimes when they receive the spray, a lot of patients do complain of some discomfort post-op. Actually,
that's
a lot of them say, "Wait, I'm not able to swallow. I'm having some breathing difficulty." So a lot of patients do complain in non-neurological surgeries like endoscopies and other places. I know earlier some people used to use. I know when I was training in neuro-anesthesia, one of my senior professor used to instill lidocaine into the cuff, ET tube cuff.
Yes.
To prevent intraoperative, we don't have remifentanil propofol during that time. So when you're monitoring facial or monitor with intravenous total it's a gas-based anesthesia, so he used to put lidocaine, instill lidocaine into the cuff to prevent the airway response.
Yes.
So these are all practices.
Absolutely.
Nice to come across. You'll come across such practices when you're training, when you're seeing others.
The cuff, I think the lignocaine with instilling the cuff with lignocaine, and that has been studied, and there's a variability. In some, they won't even diffuse. Lignocaine won't diffuse out at all. In others, there might be a small amount diffusing out over long surgeries, but otherwise that has not been proven.
But I'll tell you one interesting thing, Dr. Shiv. So in our institute, we did a survey among all patients who received general anesthesia, like for a brief period of time, and the most worrisome fact for the patient, that the patient's complaint was not pain, not nausea, not surgical pain. It was a sore throat. So this is a major issue that most of us are facing with the post-operative period with our patients, and we kind of assume that this is a part of the package, and I think we need to find an answer somewhere. So maybe one thing is I've started using a smaller size tube. Before I used to use a bigger size tube. The bigger the size tube you pass, you feel more secure the airway. I mean, as a probably initial years you had that feeling. I think slowly coming down on the tube size and keeping the cuff pressure good enough, monitoring the cuff pressure, small things. I think. What do you say, Dr. Shiv?
Yes. So I think this has been, there is a bit of literature on this. Dexamethasone, like we say that we use it left and right, but that has been shown to reduce this sore throat. It's called post-operative sore throat. That's the acronym used for that. But yes, it is worrisome in some cases. Tube small size, we have always been talking about using smaller tubes. So for most females, we tend to use size 7, a male 8. And even for the biggest patient, even if they are 6'7" tall and big patient, we still use 8.5. I don't use more than 8.5 tube for most cases. So smaller size tube is important. Magnesium sulfate, maybe. So I think it's all multimodal, non-steroidals. I don't know how often you guys use non-steroidals in neuroanesthesia, but I think I tend to, look after and look at all these kind of things, and I've not seen sore throat in my patients. But I give everything to them.
Less use of antisyllagogues like
Exactly,
glycopyrronates and
dryness.
everything.
Yes, dryness. One of the commonest causes for sore throat is dryness, and very common practice in India. People giving glycopyrrolate left and right, or I think that's not required at all. I think I don't know what. Even for the airway, if I have to do a awake intubation, I don't use Salagog. I'll sit them up, let them swallow it. It's not
I think yes.
a problem.
Glyco is slowly,
Yeah.
I mean, it has to go. No need of glyco for all patients. I think I
Exactly.
totally agree with that.
Even I don't use glyco routinely for all the patients. Very minimal.
It's a bad
This.
thing.
Yeah.
Yeah.
Cuff pressure is very important thing for a sore throat, we have seen, and in our experience here, we monitor the cuff pressure after
Yes.
intubation, and we have seen almost very less incidence of patient complaining of sore throat here.
So coming to the other questions on ERA's use of scalp block, Dr. Raghavendra again commented that there is some role of adding adrenaline to ropivacaine. There was a question about use of instead of using lignocaine with adrenaline, of using just there's to talk about the long-acting and short-acting local anesthetics. But I think one of the things which the surgeons also, especially for craniotomy, they like to have is a bloodless field, and they tend to use, adrenaline with their local anesthetic.
Yeah.
So
So
there is
surgeons definitely for the incision, they have an infiltration of lignocaine with adrenaline. It reduces their blood loss with the flap, and so it makes it. So I think a triple approach of scalp block, pin site infiltration, and a skin infiltration on the incision will give a complete good block, and it can reduce the requirements.
So what my approach, I mean, some of the spine cases where they need to go prone, obviously, and they're using the Mayo frame, they use that. So I think if the surgeon wants to use adrenaline for infiltration, they can always tell them to use it with saline, just dilute with saline rather than. So you use your long-acting local anesthetic for blocks and let them use adrenaline, diluted adrenaline for infiltration. Then Dr. Bharti Mohan asked about what about, we were talking about maintaining the mean arterial pressures during the surgery. And he says, what about using low dose noradrenaline or norepinephrine during the procedure? I think we did talk about, like Vijay was saying, that they don't no longer.
Can I answer that, Dr. Shiv?
Yeah.
So earlier we had that doubt in the mind. Norepinephrine can cause ischemia if there is extravasation or thing. I think last year, we had a very large randomized large study showing a low dose norepinephrine can be used in the periphery. I think that has answered the question. So yes. I use norepinephrine, low dose concentration norepinephrine. Try to put it in a bigger gauge needle. Don't try to use it in a 20 or 22. Try to put a bigger size. Try to put diluted. Try to put it in a cubital fasa. Your IV cannula. I have used them, especially carotid endarterectomies, because the reason why is a lot of these patients have very significant atherosclerosis. And sometimes not I've noticed they don't respond so well to phenylephrine.
Yeah.
Especially with a lot of diffuse atherosclerotic disease, cardiac issues and all. So in such patients, norepinephrine works well. And carotid endarterectomy, you don't want to put a center line. So low-dose norepinephrine, yeah, it should be used. And we have a literature to back it up now.
Yes,
So,
we've been
we
using
have
it for a very
started
long time.
in our center, but it's in much diluted dose what we are giving to center line. So center line, we are giving around 4 to 8 milligram of noradrenaline diluted. But here we go up to much lesser. I think it's a 2 milligram or even the less than that.
Here we use 4 milligram in 250 ml infusion bags.
That's right, Vinay. That's what we've been doing that for a long time, because we were the center for the vascular surgeries, and people needed to maintain carotid artery surgeries. Or even for that matter, even patients with having aortic stenosis, where you don't want to just put it says, 1 hour
Recently,
surgery or so.
sorry, sir. Sorry, extremely sorry.
Yeah. So we
Recently,
were giving 4
sepsis
milligrams
also-
in 250 mLs.
Right.
Yeah.
Recently, the sepsis trial also, as Dr. Vinay said, you can
Yeah.
use the vein above the cubital fossa. They have mentioned about the larger veins to be used, and you use norepinephrine rather than not starting norepinephrine to maintain the mean arterial pressure. So bigger veins with the bigger cannula can definitely help in maintaining.
Yeah. Excellent. So coming to the next question. Well, I think that was answered, that this was about giving spinal in traumatic brain injuries. I think that was answered. After how many days can you actually give a spinal anesthesia? Like I think Nitin already answered that after a week or so, you can assess and then go ahead. I think that was answered. Yes, so awake craniotomies, that was an interesting discussion about SAS technique, sleep awake sleep, or sleep awake SAS versus SAA technique. But coming to the cervical spine surgeries, there was discussion about whether you do manual inline stabilized mills, or use fiber optic or VLS, and I think Vijay mentioned very clearly that of that most important thing is to maintain oxygenation. But I didn't actually see any discussion whether it would be a good idea to use high flow nasal oxygenation, which became very popular during COVID time. Should that not be used in these cases, so that there is, constant oxygenation is maintained, you're not stressed out about?
Coming to that, I frequently use high flow nasal oxygen when I'm doing awake fiber optic nowadays. Nowadays I do, and it is definitely helpful. You can just go by the side of the you can at least have that time premium, even if there is any issues. So yeah, it's a very good option. With after the COVID, with easy availability of high flow in most of the centers, that would be very useful.
And even if you do not have the machine for that, if you have nasal, specs with 15 days called no DSAT technique, you have already anesthetized a patient, so they will tolerate. Just put the nasal specs, increase the flows to 15 liters, and it does actually provide you some amount of a safety net. So I think you should be actually using that.
Included in difficult airway society guideline also, high flow nasal.
Yes. Yeah.
Like the Thrive technique here.
That's the Thrive technique. Yeah.
Yes.
Thrive technique or no DSAT. No DSAT is with just nasal specs, whereas for the Thrive technique, you need to have the machine to deliver 70 liters, 60 to 70 liters per minute of oxygen. So there's slight difference in that. This may sound a little ambiguous. Sayak Saha, I think that is. He asked about, if you have a patient with C-spine injury and head injury, which surgery are you going to operate first? Would you do a craniotomy first or cervical fixation first?
It depends on this, whether the spine is stable or not.
Yeah.
No, the question was cervical spine and a brain injury.
You got a patient. So you got a patient who's got head injury as well as a spine injury, and patient require craniotomy as well as cervical spine fixation. Which surgery do they normally go for first? Do they fix the spine first, or they go for craniotomy and then fix the spine?
Brain first for sure, because the patient will not survive without
Yeah.
a brain, and then the cervical fixation also has to happen, but you never attempt a cervical spine fixation without fixing the brain. So that's
Right.
the take home
Right.
message.
That's why
Otherwise
it's
you'll have a fixed cervical spine, but the
no brain.
patient may be brain dead.
But practically,
No.
is coming with these two injuries. It's a very high velocity, high impact injury. Patient survival is next to impossible.
I've done few cases, such cases with cervical spine injury, and so usually, like Nitin said, brain surgery is taken care of first, and then once they recover, they come back for the spine surgeries.
So usually in our center, it is located in the periphery. So, but just on the bypass of the city. So sometimes we are getting these kind of patients. So we secure the airway, go ahead with the craniotomy, and
then fix the spine. Yeah. So it's not an uncommon situation. The brain has to be first. There's no point having a good fixation of cervical spine.
Positioning, it will move. The spine will move.
Yeah.
No way the spine can be immobilized for a cranial.
Yeah. I think.
So mostly all these, I feel mostly those patients who are going for these two injuries, they have a stable spine, but they need to be fixed for the mobilization and physiotherapy and all those things.
Yeah. But if there is no neurological, okay, fine, they could actually have an unstable spine. Does not mean that. We do actually have patients who wait for, sometimes hours and days to actually have the cervical spine fixed. They're in the rigid collar, and then we try to get them ASSP, but then still, you can wait unless the patient is showing signs of neurological deterioration. You would actually wait.
I think the other take-home message here should be that in all brain injuries, patients should always look for spine screening also and have an idea about how the cervical spine is.
Yeah.
Because you might miss out on a possible cervical spine injury on a patient who's had a brain injury. So you should do, the nexus criteria, the Canadian C-spine rule. These are all good criteria to look at. If you're doing both injuries in your center, then you should know these.
Yeah, the fixing cervical, fixing fractured spine is a big discussion domain in surgical field, either early fixation or late fixation. I am not led about the data, but I know there are both pros and cons. There are discussion on people discuss on either side, early fixation and late fixation. There are both pros and cons in both the sides. But I don't know the literature. What is the current literature? I'm not very much aware.
Yeah, I have actually done few very bad cervical spine cases, and early fixation, we did actually have very good results. So I'm for the pro. I'm not doing any more the spine because they moved to another center. But I was pro for actually getting the patient as soon as possible. There was another question about coming to, I think, somewhere related to this head injury, patients who are on antiplatelet drugs because of whatever reason, and then they have a head injury, or what do you do about hemostasis? I think this is Dr. Bharti Mohan asking this question. He's got another question which I'll come back in a minute.
So what we do here is if we get to know the patient is on antiplatelets, so we have a state of art of thing. We can check the aspirin inhibition or clopidogrel inhibition by aspirin inhibition test and clopidogrel inhibition test. Yeah. However, if it is a moderately or fully inhibited, then giving platelet at that time and then taken for a surgery, it's not going to make much difference, because the circulating aspirin or whatever antiplatelets given, they will bind to a new platelets and it will be futile. So we take the patient in, start the craniotomy, arrange the platelets, and if it is visible that even the patient is having oozing, start the platelets at that time. So there will be effectively plug formation rather than giving early and neutralizing whatever the new platelets we have given.
Yeah. And again, the use of tranexamic acid, because if you have formed a plug, you stop it from breaking. Fibrinolysis is also important part, isn't it?
And
yes.
and
Cardiac
and
crisis.
there's a role of ROTEM also. So we started doing a ROTEM in all those cases. So we'll have a baseline ROTEM done, and top of that we can decide which kind of a component the patient will require more. That can be arranged.
Yeah, I agree with Dr. Vijay. I think we mostly decide intraoperatively when the surgeon says that, it's a very oozy field and we have to give some platelets. And here the platelet counts are normal. It's only that the platelet has been inhibited. So remember that even with a platelet count of normal platelet count, if you have antiplatelet drugs, you can have an on-table ooze, and then, like Dr. Shiv said, tranexamic acid and giving fresh platelets then on table may help to plug the and get a good hemostasis.
I fully agree with Vijay sir and Manohar sir that it is thrombocythemia. It is not the actual this thing that is affecting it. And intraoperative is the choice, always, depending upon the surgeon's part.
So there was another question for Dr. Bhartiman. He said, could you tell about something about code brain? Nitin.
So code brain is a situation when suddenly a patient has had a brain insult. So it's like, it can be a stroke, it can be a raised ICP, it can be a sudden neurological deterioration. So then you call for this code, and then immediately a patient has to be neurologically assessed. Patient has to be done. CT scan is a must. I mean, that's the best go-to immediate imaging modality. And then we decide as to give, whether to go for medical therapy with hypertonic saline or mannitol, or we immediately take the patient for some kind of a surgical intervention or a decompression. So this is, in most of the neuro units, this is called as a code brain. And that means that the system is activated and everybody is alerted. The OR is ready for a probable procedure. The CT scan room is also, the elective CTs are stopped, and then the patient can be accommodated immediately, because you have to act, because time is brain. And if you allow the brain to, if you take time, then the the more neurons are going to get damaged. So this is a typical code brain, which most centers who have a neuro unit will have in place.
Mukilan, now what would you actually suggest say, for example, this is on the ward and code brain has been activated. What would you advise the general, say maybe a general anesthetist or someone who's not doing neuroanesthesia, or what would you tell them that they need to do till the neuro team arrives?
So mostly the patient had a neurological insult. You have to think on the most basic things which should be given first, like checking the blood sugars, which can reverse the patient, giving the oxygen supplementation, making sure the basic neurological assessments are done, and making sure the patient can be shifted to an CT scan room with a monitor and the setups and proper IV lines which has been established if he is an hypovolemic or those things. So those steps should be done before the neuro team comes. So I would agree for inserting an IV cannula, taking a blood sample, supplementing his oxygen, monitoring his vitals, and getting ready the patient for a CT scan will be a wiser option. Yep.
Would you also suggest about the blood pressure monitoring and
yeah, exactly.
PSA,
the monitoring implies everything. Yes.
Okay.
And one more,
Doctor.
One more, Dr. Shiv.
Yeah.
It's not only for anesthesiologist, even for a general anesthesiologist working in a center, like a peripheral center or a second tier city or something, administering early IV TPA.
Yeah.
I think code brain, one of the most common causes in the current world scenario will be stroke.
Yeah.
Administering IV TPA has a very significant impact on the patient's morbidity and mortality. So if you're working in a tier 2 city, just try to remember this. Apart from all this, what Mukilan said, maintaining the patient's homeostasis, starting a treatment like IV TPA, like just like aspirin in patient having an MI, starting an IV TPA after ruling out all the contraindications is very essential.
Okay, I think that's a
Yeah,
very good
that can be
message.
done once the CT scan is done and you are ruling
Yeah.
out the hematoma. Then
Yeah.
you can start on table of the CT scan. You can start the
TPA.
IVTP. That's the best thing.
Absolutely.
Yeah.
Fantastic. I think that's a great message for people to actually consider. So you accompany the patient, and once they show that there is nothing, no bleed in the brain, just give it IVTPA. I think last question of the day will be, this is Girish asking Nitin specifically. When you stop dexmedetomidine infusion before extubation, or you continue till extubation, do you stop it beforehand, or do you
Yeah, I think
continue?
dexmedetomidine, I would just stop like when I'm attempting an extubation, I just stop it like probably 10 minutes before I would stop it, so that it has some residual effect. The dexmed guys wake up a little late, so to minimize that, I would just stop it, and the effect continues for some more time, and then you can extubate them. Though with Remi, I think you don't need dexmed also. So the problem comes when you don't have Remi. I think most of the people listening in India, I've heard that remifentanil is coming. So
Yes.
your better days are going to come, because I think we have all seen the Remi, and once you see Remi, you don't see anything else. So it will solve most of the problems.
Yeah. One thing
Yeah.
about Remi is that if you actually have it on low concentration running, you can have patient who is awake and he won't breathe. You have to actually tell him, take deep breaths. They
You can
tolerate that.
extubate on Remi.
Absolutely, you have. So you can continue Remi, and within 3 minutes it's gone. So you don't worry about his residual effect. I think that's the biggest difference between Remi and dexmedetomidine. I think
Sir, may I add
one
one
thing.
thing?
Sorry, go on, Mayank.
Actually, sir, I am extubating on dexmedetomidine. Right. I continue a basal infusion of dexmedetomidine, and it helps to prevent the reflexes. And at the same time, the patient just opens up her eyes. That sweet spot, as Vijay said, it comes with time. It comes with time, but for the beginners, it is always better to stop dexmedetomidine, check the reflexes of the patient, and then extubate.
I think in the end, it is about experience, like you said. It is experience of the particular anesthetist, and when
point with the
to stop and when to start. Sorry, yeah, Vijay.
Yes, sir. One point with the remifentanil is we should not forget to give a proper analgesic at least half an hour or 15 minutes before extubation. Otherwise, it will be counterproductive. Vitals, hemodynamics will be mayhem, and controlling at that time will be very difficult.
I think
when remifentanil comes into the Indian market, Dr. Shiv, you'll get busy. You will need a proper remifentanil, because all of us who came out and started using Remi, we've seen the game now. So it's initially it will be a challenge.
Yeah, we will. I think
One more point I want to add here is all of us should remember, like we're using remifentanil. So remifentanil induced hyperalgesia is a big thing in the literature, with producing a lot of chronic pain afterwards. So adding dexmedetomidine or ketamine background infusions are basically in the literature have been used to reduce the dose of remifentanil used, so that we can prevent the hyperalgesia. So we should, even if the remifentanil, we should always look into other sources to avoid reducing the dose of remifentanil. That's also more important, I feel, in our clinical practice.
Just for my knowledge, I wanted to know that many people are coming up with combination of remifentanil and midazolam in the pharma industry. What is the advantage of these things? How are they? What is the purpose of this thing? Just for the public knowledge as well as for us.
Remizolam is are you talking about Remizolam?
Yes, I just wanted to, in this discussion, let us have a word about that also.
I think it's what we're going to do is, I think once remifentanil is launched or Remizolam is launched in India, we will have a few sessions on that, specifically because we want people to use remifentanil properly to understand, so that patients are not affected by it. As far as the neuro patients are concerned, I think one of the biggest thing which can make a change, and that too in general practice as well, is use of blocks. So when you're using this, One thing is using high doses of remifentanil is not always required. Okay, it's a myth that you need to use very high concentration to stop patient from breathing. No, patient will stop breathing with a concentration anywhere from 3 to 6 nanogram per ml concentration, plasma concentration. So you can actually keep them ventilated. Yeah.
Patient moving at 8 remifentanil, or it's not only the breathing, it's like patient is on pin. We don't want the patient to even move.
Yeah.
Specifically, if the surgeon is operating and patient bugged, that is disaster at that time.
So that's what I'm coming to that. So if you're looking at, because like I said, I have used quite a lot for spine surgeries where they use Mayo frame and put pin, you need to use regional anesthesia technique. If you actually put that, the patient will, you can maintain them. Anesthesia is mainly maintained with propofol in that, because that's why you maintain the anesthesia and stop the movement of patients. But the pain, you can prevent pain by using regional anesthesia techniques, scalp blocks, like giving pin side block. Well, those things become very, very important in that. But if you're not using it, you're right. You need to give something at the end when you're stopping the remifentanil. Otherwise, patient will wake up with a lot of pain. And that what complicates things in neuro-anesthesia. On one side, you want to be awake. And the last thing, you want to give them something which might make them drowsy, make them vomit. Okay. So that's I think a very smooth technique requires to use appropriate anesthesia, not just give, okay, fine, I'm going to stop remifentanil, so I'm going to give 15-20 milligrams of morphine. That doesn't work. So coming to the, like I said, I think Troika is launching remifentanil in India, and once it's launched, we will actually have few sessions on that, how to use it properly. We'll discuss that during that time. So thank you very much, Nitin, once again for hosting this, and thank you, Vinay. Thank you, Mukilan, Vijay, and Mayank for joining us.
Thank you,
Let's wait for the next one. I think there is
so much,
lots of nice comments thanking the group. I think everybody said that this was a wonderful discussion, a wonderful session, and everybody has got a take-home message, and I think everybody enjoyed it, including us.
Yeah, we enjoyed it.
We enjoyed it even better.
Anticoagulation and neurosurgical patient will be a good challenging subject to discuss the next time. Yeah.
Okay.
Sometime in the next time.
Yeah. I'm going to end the live streaming now.